On behalf of the Transport Symposium Planning Committee, which included a team from the School of Public Health, Brooklyn Health Disparities Center, and the leaders of transport, thank you to everyone for attending our 5th annual event. And now, please welcome Dr. Marcus Lambert, Associate Professor in the Department of Epidemiology and Biostatistics, School of Public Health, and also Associate Vice President for Research Strategy and Operations. He is also one of our transport principal investigators, and he will get us started. Good morning, Dr. Lambert.
Good morning, Dr. Straker. Thank you so much. I appreciate that introduction. Again, my name is Marcus Lambert, and on behalf of the Principal Investigators of Transport, I'd like to officially welcome you to the 5th Annual Transport Symposium, Advancing the Science of Community Engaged Research, Lessons Learned from COVID-19. As Dr. Straker may have mentioned, the symposium is hosted by the SUNY Downstate Health Sciences University and the Brooklyn Health Disparities Center. And I want to especially thank the CME office, the School of Public Health, all of the members, the fantastic members of the symposium planning team, and particularly the National Institute on Minority Health and Health Disparities, NIMHD, for their support. In 2017, Downstate was awarded an NIMHD-funded Health Disparities Endowment Grant for $10 million that has not only provided the support for this very symposium, but has afforded us the opportunity to establish transport. And as Dr. Straker mentioned, the goal of transport is to recruit and train health equity researchers who come from underrepresented groups. We support a range of activities from undergraduate and student pipeline programs, faculty development, postdoctoral training, symposia, and seminar series. And I think we all know that the lack of diversity in science and medicine has perpetuated health disparities. Just last night, I was actually at the gym and I met 2 young African-American males from Brooklyn. We started chatting about the basketball game, and one was pre-med from Medgar Evers. The other was a graduate of Downstate from our occupational therapy program. The pre-med student asked me, what was the biggest challenge that you faced in getting your PhD? I paused for a second and I said, that's a very good question, because I received my PhD in biomedical science from NYU and a master's in clinical epidemiology and health services research from Weill Cornell Medicine. But in any of those cases, it wasn't about the content. I told him, actually, it probably was the lack of community. So we really count on programs like Transport to help us recruit and retain talented research scientists from underrepresented backgrounds. And more broadly, Transport has allowed us to have this very platform where we can bring communities together. Our goal here today is to provide a platform to advance the science of community engagement. And we can't talk about community engagement without considering the totality of COVID-19. Even as COVID-19 cases subside, we will still be staring at health inequities brought on and maintained by systemic racism and discrimination. Our approach to community engaged research after these pandemics cannot be the same. The science must change, the approach must change. And this requires community partners coming together with academic partners to drive a new community engaged science agenda. So here we are together. And like the famous African proverb, if you want to go fast, go alone. If you want to go far, go together. So with that, I'd like to introduce the president of SUNY Downstate Health Sciences University, principal investigator of transport, and recently appointed co-chair of Mayor Eric Adams' COVID-19 Recovery Roundtable and Health Equity Task Force, Dr. Wayne Riley.
Well, good morning, Dr. Lambert, and all to the symposium participants and supporters. Thank you so much. Thank you, Marcus, for that wonderful table setting for this wonderful symposium. April 4th will be my 5th anniversary as president of this great university. And I can tell you the highlight of my first year as president is when we received word that we had indeed been awarded the NIMHD Research Endowment which allowed us to create the transport program that Dr. Lambert just talked about. I remember the day when we got the news, because I knew this would turbocharge, colleagues, our ability to attract, mentor, train, and what Marcus said was very important, create a community of support for investigators who were interested in health and health disparities. So this is just one of my, points of pride that our team, it wasn't just me, it was our team here at the university who put together this great application, and we've been successful. I am amazed at the work that the transport program has done over these 5 years. We have great plans to expand. This symposium is just sort of a glimpse into the wonderful work that we have done with this very impactful grant. So again, I couldn't be happier at where we are. I want to thank Dr. Booten Foster. She was involved at the early phases of this, Dr. Straker, Dr. Salafu. We all sort of strategized and wished and wondered whether we could get this research endowment. And here we are 5 years later, and I'm very gratified. I don't think he's on yet, but I want to also, extend my welcome to Dr. Alicio Perez-Tablay, the second director of the National Institute Minority Health and Health Disparities, the Institute. I don't know if you know this, I'm a fan of history, particularly academic politics and scientific politics, but I chaired the advisory council for NIMHD when it was just a center. And one of the things that we had all aspired for at least a decade or so was to move the minority health and health disparity agenda to a full-fledged institute at NIH. And I will tell you, this took more than a decade. I worked on this when I was president of Meharry. We had at least 2 NIH directors who were flatly opposed to doing this. But we persisted, and we were successful in getting the authorizing language to move the institute to the center rather, to a full-fledged NIH institute in the Affordable Care Act. So I give great kudos to former President Obama, Speaker Pelosi, then Majority Leader Harry Reid, and all of us who really just pounced to get the minority health and health disparity agenda at the highest rung within the NIH portfolio. And we did that with the passage of the Affordable Care Act. So I want everybody to know this just didn't happen overnight. It took well over a decade for us to get our institute, if you will, at NIH. Additionally, I had the wonderful honor of serving on the search committee that selected Dr. Perez-Tablay as the second director of the Institute. The chair of that committee was my friend, Dr. Anthony Fauci. So I take great pride in that Dr. Perez-Tablay has been an outstanding second director of NIMHD, and the role that I played along the way to get it to where it is so that it could have great programs just like this and expanded beyond just the minority serving institutions, one of which I led for almost 7 years, but to other institutions like ours who have impact in diverse communities all over the country, and particularly here in New York City, the most diverse city in all of the United States of America. So colleagues, I couldn't be prouder and happier to set the table along with Dr. Lambert and Dr. Straker and welcome all of you. Welcome our terrific speakers. Welcome Dr. Perez-Tablay when he joins, and thank all of you for your amazing contributions to moving forward on creating, the beloved nation that the late John Lewis used to talk about. It wasn't about just politics. Congressman Lewis understood that in order to create the beloved community, that it also meant that people had to have healthier lives so they can enjoy each other, their communities, their work, their livelihood, their friends, their families, their avocations, their hobbies. So in that spirit, Thank you very much for what you're doing. I am just so pleased with where we are, and I look forward to further progress on our wonderful portfolio of health disparity research, mentoring, education, and training as part of Transport.
Dr. Riley, I just want to mention Dr. Perez-Stable has joined us already.
Oh, great. Alicia, welcome.
Thank you for those kind words, Dr. Riley. I kind of knew I knew you from somewhere, but that search committee day was definitely memorable for me.
It was a blur, I remember, but we're so happy that we recruited you, Alessio, and just a wonderful work that you've picked up, at the center. So salute to you, and it's one of my points of pride that I could say I was on the search committee that attracted you to NIH to lead our great institute. So welcome.
Thank you so much, and good for that background history too. It's always, I'm also a fan of history, so thank you.
Great. Well, good. Be well.
Thank you, Dr. Riley, for all of the wonderful work that you're doing to advance our efforts in tackling health disparities. Before we get to our keynote, I want to provide or present a virtual welcome from the Brooklyn Borough President's Office.
Good morning, everyone. This is Diana Richardson, your Deputy Brooklyn Borough President. On behalf of our amazing Borough President, Antonio Reynoso, it gives me great pleasure to welcome you to the 5th Annual Transport Symposium. Although founded in 2004 as a partnership between the Brooklyn Borough President's Office, SUNY Downstate Health Sciences University, and the Arthur Ashe Institute for Urban Health, the Brooklyn Health Disparities Center's mission of eliminating health disparities in our borough became ever more critical during the COVID-19 pandemic. As a local Brooklyn elected official who has represented a predominantly African American and Caribbean district, together we experienced firsthand the impacts of COVID-19 on our community. But the disparities that the pandemic highlighted were not new to us. The time has come to close these health disparities once and for all. Today, we join SUNY Downstate and the Arthur Ashe Institute for Urban Health in this symposium to explore how we might better engage the community to advance its collective health. Today, we endeavor to bring solutions to long-standing problems that interfere with those goals. And as we move forward, it is important that we are intentional and deliberate because the health of our community depends on it. So please enjoy the symposium and let the meeting of the minds begin.
Wonderful message from our Deputy Borough President, Diana Richardson. I want to also make sure we acknowledge and introduce other members of Transport, particularly our Transport principal investigators. For the sake of time, you'll hear from them throughout today's program, and they'll provide some remarks. But I just want to make sure and acknowledge the wonderful work of Dr. Moro Salafu, professor and chairman of the Department of Medicine and director of Brooklyn Health Disparities Center, and Dr. Carla Booten-Foster, who much of this symposium was really her idea, her brainchild. Dr. Carla Booten-Foster is Associate Dean of the Office of Diversity, Education, and Research and Professor of Medicine in the Department of Medicine. And I also want to acknowledge our Transport scholars, Dr. Adi Jumbo, Dr. Kutsia Banu, Dr. Marlene Camacho Rivera. They will participate as discussants throughout the symposium. And I will actually turn it over to Dr. Portia Thomas, who's a Transport scholar and a nurse scientist and postdoctoral associate in the Department of Medicine and a part of the Special Treatment and Research Program, our STAR program here at Downstate Health Sciences University. She's going to provide a few opening remarks on behalf of the Transport scholars. Dr. Portia Thomas.
Thank you, Dr. Lambert. Good morning, everyone. I am Dr. Portia Thomas, a postdoctoral associate and a 2020 Transport scholar. It is my pleasure to speak briefly about my experience as a Transport fellow. The Transport Fellowship provides opportunities for junior faculty and postdocs who are members of an underrepresented group in bench, clinical, behavioral, or social sciences. The program aims to increase the diversity of academia by elevating the research skills of minority scholars working in health disparity research. Through mentorship and training from Transport's principal investigators and other senior researchers throughout SUNY Downstate, fellows receive hands-on experience and guidance to become successful independent researchers capable of achieving high ranks and recognition in academia. As an African-American nurse scientist, I can attest to Transport's benefits for novice academic professionals like myself. Through mentorship, trainings, and financial support, I have dedicated time to focus entirely on my research program. As a graduate and doctoral student, I did not have opportunities to connect with senior researchers or establish a research mentoring team. And unfortunately, this reality is common among other minority scholars. We have the drive and aptitude to be successful independent researchers, but without building our capacity through collaborations and advice from experienced scholars, outlining a promising academic trajectory is daunting and challenging. My research program aims to understand and support decision-making among HIV vulnerable communities, especially racial and sexual minorities. I am fortunate to have been paired with mentors, Dr. Sabina Hirschfield and Jack DeHovitz in the STAR department. They have supported my growth as an investigator and introduced me to other researchers in my field, creating possibilities for future collaborations. With their expertise, I am currently conducting 2 studies with high scientific rigor for conducting HIV prevention online and community-based studies. Dr. Booten Foster has also been very instrumental in my development, informing me of additional mentoring opportunities to learn from scholars across the country. And as a result, I have attended NIH writing workshops and applied for additional grants and fellowship programs with some success. I consider it an honor to be a transport scholar, as it has opened doors and extended resources that will propel my research career forward. Thank you so much for attending our symposium today. I will now turn it over to Dr. Amy Affable, who will introduce our keynote speaker. Dr. Affable is the Associate Dean for Community Engagement and an Associate Professor in the Department of Community Health Sciences, School of Public Health. Dr. Affable.
Thank you, Dr. Thomas. Can you all hear me? Yes. Thank you, Dr. Thomas, and good morning, everyone. I am delighted to introduce the Downstate community to Dr. Eliseo Perez Estable. He is the director of the National Institute on Minority Health and Health Disparities. His research interests span a variety of areas, but he is most recognized as a leader in Latino healthcare and health disparities research. He has dedicated more than 30 years leading research on smoking cessation and tobacco control policy in Latino populations, both in the United States and in Latin America. Prior to his tenure at the NIH, Dr. Perez Estable lived in the SF Bay Area, San Francisco Bay Area. He was professor of medicine at the University of California, San Francisco, and it is here at UCSF where I first met Dr. Perez Estable. I was a postdoctoral scholar, and through a pilot award from his NIH NIA-funded Center for Aging in Diverse Communities, he became my mentor. It is also here at UCSF where I first learned of the critical and central importance of setting up support systems for mentoring young scholars, particularly those who want to pursue independent research careers supported by agencies such as the NIH. Dr. Perez Estable's leadership and supportive team of faculty, as well as the systems he was influential in creating at UCSF, has been the gold standard for me in mentoring strategies since then. Beyond his impressive professional qualifications and accomplishments, what I would like to share with you about Dr. Perez Estable is that he's an immigrant of Cuba who was sent by his parents to US as a child to live with his grandmother due to the fear of rising communism. You can imagine the profound impact that experience can have on a child. And it is through this lens and with a lived experience and appreciation of what it is like to be foreign or different from the dominant US mainstream that Dr. Perez Estable approaches his work It has inspired scholarship in acculturation and novel health assimilation trajectories, which I have benefited from personally, as we have a shared curiosity in this area. His childhood experience has also inspired his dedication and advocacy for supporting and training a new generation of scholars who have been historically underrepresented in biomedical and population health research, and for creating systems and structures, including structures at the NIH, to open channels to support their ideas. Dr. Perez-Dalby is not only a leader in health disparities research, but a pioneer. I am privileged to know Eliseo and delighted to introduce the Downstate community to him and him to the Downstate community. Welcome, Eliseo.
So thank you so much, Amy. That was a wonderful and personal introduction. I appreciate that enormously. I wish I could be there in person. I think we're getting closer to that, although then I'll do fewer of these talks if they have to mean travel. It's also a revelation to actually connect the dots and meet Dr. Riley. That was really great. And I noted that he's a primary care general internist as a background like I am. So I think that's another theme I've brought, I think, in part to NIH. I'm going to share my screen. I think my charge was to keep my remarks to about a little about 30 minutes or so. So we have plenty of time for conversation. And I was asked to focus on community engagement issues, and that's very, very, very central to today as we are now approaching the second anniversary of the beginning of the pandemic. So it's wonderful to learn about the transport. I always learn so much from actual visiting places or hearing directly from people rather than just reading reports. And so it's great to see what the endowment program can do. I trust that we're going to have the ability to continue and expand that in the near future. So let me start. Everybody can see my slides, I trust, or people would have started complaining. So I'll start with what our population with health disparities are and put this in context. The first three bullets included in this slide were actually part of our legislation in the year 2000 when we were created as a center. So all racial and ethnic minority populations, as defined by the census, understanding some people are wondering whether we should continue to use the term minority as the population grows. The people of quote unquote low socioeconomic status, I prefer to use less privileged socioeconomic status, and this is most easily defined by education, although ultimately it comes down to income. Rural residents was in the original legislation, and we qualified it as underserved, given the target population here. And I think this was a strategic addition back in 2000 that serves us well today, given the situation with rural populations in America. It's about 18% of America. If you want to know the percentages, about 40% of the United States now would self-identify as a non-white population group, or mixed race, or more than one race. And 15% of Americans live under the poverty level, but probably this category captures about 30% of the country. And in 2016, we declared sexual and gender minorities as a population with health disparities for NIH research purposes. This was a process that began under Yvonne Maddox as acting director. It was championed by the NIH leadership at the time, and I was there when it went through the final phase with the department, and so that was an important, I think, hallmark for expanding research. Up until then, it was don't ask, don't know approach to issues around sexual and gender minorities, except for selected investigators. We endorse the idea that all of these groups have a social disadvantage based on a demographic or identity characteristic, not a condition or disease, that results in part from being subject to discrimination or racism, and therefore also being underserved in healthcare. So a health outcome in any of these populations, compared to some reference group, defines, in our view, a health disparity. So not all differences are disparities, and certainly not all of these groups do worse in health outcomes. I think those are important points. a point I have tried to make at NIH when I realized this wasn't generally accepted by everyone is that race, ethnicity as a self-identified social construct, and there's no debate about that at NIH from my colleagues at the National Human Genome Institute. It's a social construct. There's no question with different components. And then socioeconomic status, however we define it, are really fundamental factors that influence health, that determine health, and therefore should always be measured in a reliable, consistent way. We should do it the same way across the research and clinical care spectrum, and consider it as a possible explanatory or associated factor in health outcomes. Doesn't mean it's always going to be important, but it should always be evaluated, much like we do now with gender or sex, and other factors. So if you look at these conditions, so it predicts life expectancy and mortality, and people have known this for decades, and yet we don't really fully understand all the factors that go into that. If you look at African Americans with regards to high blood pressure, the regards cohort study showed that for the exact same level of systolic blood pressure in men and women 40 to 64 years of age, African Americans had double the risk of stroke, compared to their white counterparts in a prospectively longitudinal study. So the risk of bias or confounders there were really addressed to begin with. And we don't know why that is. There are many possible explanations, and I think this is an area of scientific inquiry that needs to be addressed. We know that most chronic diseases are more common in people who are less privileged socioeconomic status, and this is not due to bad behavior. There are many structural factors that go into this. And then even within a diagnosis of type 2 diabetes from the Kaiser Diabetes Registry, study is published now more than a decade ago, all racial and ethnic minority populations in that study have about 30% less heart disease at 10 years of follow-up. This is a study of over 60,000 people with diabetes, and double the risk of end-stage renal disease, meaning dialysis, compared to their white counterparts with diabetes. So same health system, similar care, same disease, and yet very profound differences in outcomes that we really care about. And again, I don't know anyone has an explanation for that. So what can science do to reduce health inequities? I mentioned this already, and I just want to beat this drum. We need standardized measurement of factors that affect health. We need to do common data elements. We can't be just, oh, I like it this way or you like it that way. No, we need to accept standardized measures, because big data will facilitate discovery. And this is not just electronic health records, but other factors. We've learned this from the basic science community and in genomic research, in health services and disparities. Researchers need to endorse this and develop the capacity to do data science, and we're ready to support that at NIH and NIMHD. I think our community of scientists in this field needs to be an engine for promoting diversity of the scientific and clinical workforce. 14% of US medical graduates today are from underrepresented groups. 14% of newly minted US PhDs in the STEM disciplines are from underrepresented groups. This excludes Asians per the National Science Foundation, which so it would even be slightly higher if you include some subpopulations of Asians. And yet we're not hiring these people. Our one principal investigators total about 7% at best from underrepresented groups, around 7%, 7.5%. And we're working hard to make that better. So we need to really address this. It's a crisis. You know, I mentioned almost 40% of the US population are minorities, and underrepresented groups, it's a third. We need to cultivate community engagement and build trust for sustainable relationships. I think this is a big lesson from the pandemic. Some investigators have been working in this area for almost 3 decades or 4 decades. There have been institutes that have launched programs in this. They've come and gone. There's been a consistent level of community engaged research from NIH, funded by NIH, I should say, for the last 20 years, but it hasn't really hit the mainstream. I think the time is now to really try to build that infrastructure and make it part of the mainstream. And then we need to implement what we know. It's embarrassing to see that I just mentioned about blood pressure control and about blood pressure risk in African Americans. And when you look at the Medicare data, the group that has the least likely to have control of blood pressure, even using 140 of a systolic blood pressure, are African Americans and Latinos. And this is really not the way it should be. So the relationship of socioeconomic status to mortality is illustrated in this slide. This is a little bit dated now, but this I don't think this has changed dramatically. So if you live in a household with more or less at the poverty level, which is slightly higher now, it's about $26,000 for a household of 4, you're 3 times more likely to die from anything compared to a household where the income is $115,000. Which is fine, but it's not wealthy. And the median income in the US pre-pandemic and probably recovered by now is somewhere around $64,000. So if you look at this data and you say, well, that's a powerful predictor. Do we measure it routinely in our patients that we see? Do we know what it is in our research participants? And the short answer is probably not in most cases. And I think clinician scientists at NIH, when I showed this to them, they were astounded that this was a reality. And so I would argue that this is a critical factor that needs to be done. You can do it with education, which is a less threatening thing. People are more likely to tell you most things, but they don't want to tell you how much money they make. So there are points to say. The research, though, needs to do stratified analysis. And these are national data where you can cut the pie in many ways. It's the prevalence of obesity among youth, and then stratified by education of the head of household. In contrast, is the less than high school in this column for males and this column for females versus those with a college degree. And the college degree is becoming the new bar, where we see a marked improvement in health outcomes. It used to be maybe high school. So I purposely created this slide to contrast the two extremes as reported by this CDC report several years ago. You can see that education benefits all groups. However, the starting point is different. If we assume youth obesity is not good for long-term health, which I think is a safe assumption, you see Latinos, both males and females benefit. You see Black females benefit the least from education in this analysis, and you see the greatest benefit coming to whites and Asians. Again, starting point is usually better for some of these groups, although not for white females start off. So we need more analyses that don't just look at race, ethnicity, or socioeconomic status. We need stratified analysis. And then there's also stratification by rurality. We need all kinds of research on sexual and gender minorities. And so encourage the community, to think in these terms when you collect your data, no matter how small or large your analyses are. Social determinants of health have also been gotten a lot of traction in the last several years. This started under the prior administration in the department. And I would make a point here that most of the emphasis is on the structural social determinants, but don't forget the individual social determinants. I would consider demographics, including your own family background, your national background, as being one, where you live and play and work, your identity, culturally, religious, spirituality, all these things. And clearly everyone would agree that language proficiency, English language proficiency, literacy, and numeracy, which is grossly understudied, are really important in engaging with healthcare and healthcare system and in doing lifestyle changes or that promote health. But the structural social determinants really came under highlight because of the COVID-19 pandemic. They were already under a lot of study. where you live, the kind of housing you're in, where your neighborhood's like, how much green space do you have available, having access to broadband, which we realize how critical that is now that we're on Zoom, economic opportunity that's close to where you live, having access to transportation, quality schools, having access to healthy food. As Amy mentioned, I lived in San Francisco for 37 years, and there's a neighborhood in San Francisco called Bayview Hunters Point, which was predominantly African-American back in when I first moved there. It's now mixed primarily of African-American and Southeast Asian immigrants and Latinos. But there isn't a full-service supermarket in that neighborhood, zero. And that's San Francisco, one of the wealthiest cities in the world. And there are a lot of liquor stores, I can guarantee you that. Public safety, criminal justice issues, this is really important. It disproportionately affects our communities, and there is no easy answer and no simple point to make or change. And I think it's a complex issue our political leaders need to grapple with. Back in 2018, we began this process called through the Phoenix Toolkit. This is a website that the National Library of Medicine hosts. Several institutes had already put a bunch of measures on there. NCI and the NIDA and NIMH had used it a lot. We created our own page. It has 3 little colored houses. I won't show it, but if you go to this link, you'll see it. To really group the social determinants of health measures that we vetted, we grouped the demographic measures that already were on the Phoenix Toolkit website, and then went through an initial phase of vetting and other measures, including individual measures as well as structural measures. We've launched phase 2 of it recently. Keith Norris is the chair of the national expert committee that we brought in to do this. Our staff are very involved in this. We have a standing work group at NIMHD, and then also at NIH to look at these. And the new director of that, well, not so new anymore, of National Institute of Nursing Research is a population scientist, and she is an expert on these issues. So we look forward to seeing more work done on this. This is the framework that our staff developed in the first year I was at NIMHD on my prompting. Founded in part on the socio-ecological model, as well as the framework that we had worked on at National Institute on Aging when I was on their council with Carl Hill, Marie Bernard, and Norman Kaplan. The important point here is not causal direction, although if I was to make one, I would say it goes from right to left, but to really present the complexity and richness of this scientific disciplines of minority health, health disparities, health equity. It has different levels of influence, as you know, that go from the individual factors, including biological ones, all the way to societal ones. Biology has exploded since the year 2000, Human Genome Project, et cetera. We always worked a lot in behavior. The physical built environment topic also exploded in the last 20 years. Look, before the year 2000, you had very little research on built environment and health. And that's come to an end. And social cultural environment, relates to how people interact. And we know that positive interactions between people lead to better health. We've known that for decades. And so let's not forget that in the context of all the things we're doing. And as a former primary care general internist, I value the healthcare system a lot. There's a lot that could be done to reduce health disparities here, or potentially make them worse. And so for that 20-30% of the population that has chronic diseases, this is a critical factor in their healthcare. And of course, there are many people will use the healthcare system for acute events or crises, but I think the ongoing needs of people with chronic disease really make a big difference here. So turning to COVID, I collaborated on this analysis published last fall in the Annals of Internal Medicine to capture in crude terms the excess deaths in the year 2020. Of course, New York City was the first point of entry for COVID-19 for SARS-CoV-2 in the US. So you're very, very aware of this. But here we see what happened. This is from preliminary death reports from the National Center for Health Statistics, or CDC. Latino, Black, American Indian, Alaska Native, clearly excess deaths rates per 100,000 population among the males that was double or more, as the other data had been telling us for a while, compared to whites. And in this particular national data set, Asian excess deaths were not significantly above those of whites. I took out the Pacific Islander qualifier here because it really is unfair to that population to lump them in with Asians, and that's for further discussion perhaps. Among women, we saw a lower burden of mortality, but again, excess deaths were clearly elevated for Black, Latina, and American Indian, Alaska Native. More recently, Paula Strassel and the group at NMHC Intramural Program under the leadership of Anna Annapolis, the scientific director, published a paper in AJPH related to discrimination. This was an online survey that the intramural division launched with the pandemic. It was sampling 1,000 persons from each of these groups listed here, including half of the Latinos responding in Spanish. And then there were other sub-studies that the intramural scientists did, and we look forward to actually finishing some analysis on this and getting them published. We have some discussions with AJPH for a special issue on this. So a significant number of Hawaiian Pacific Islanders as well as multiracial adults were sampled in this study. And they showed that all racial and ethnic minority groups experience more discrimination during this pandemic exposure. The survey was done between December of 2020 and February of 2021. So just as the vaccine was rolling out, we also published an earlier study on attitudes towards whether or not they would obtain the vaccine. But you can see here the stark differences. And in fact, Asian Americans have the highest experience and the most likely risk with an adjusted odds ratio of 2.59 and 2.67 for American Indians of discrimination. And all these factors were associated with discrimination. So over these 2 years, back in May of 2020, Monica Webb-Hooper and Anna Annapolis and myself published a viewpoint in JAMA to really highlight what others had already made observations of, the fact that, and what has happened over 2 years hasn't changed dramatically. Case rates, hospitalizations, and deaths for Latinos, Latinas, African Americans, American Indians, Alaska Natives remain about 2 to 3 times that for whites, based on the CDC tracker, which is built on data reported by the health departments across the country. So the CDC may have some issues on reporting data, but they only report the data that's coming to them from the health departments. We know the cause for this is more exposure and risk due to social conditions, jobs, and access. Omicron surge may have been somewhat of an equalizer because it was so infectious that the reduction in risk from being infected by the vaccine was attenuated substantially, as well as mask wearing. However, the global statistics don't, when you look at hospitalizations and deaths, these are hard outcomes that are difficult to debate. It has been estimated that Latinos have lost their resilience advantage, their paradox advantage, which in life expectancy is to be determined as time goes on, and whether this was held, but 2 to 3 years of lost life expectancy, and that African Americans have lost a year of life expectancy. And this was one area where disparities had been markedly reduced over the last 2 decades. And in fact, for persons over 65, life expectancy between Blacks and whites was essentially eliminated as of around 2008 or 9. Vaccine hesitancy was very high among African American communities initially. I think the mobilization of community leaders, the professional societies, work that we did, as well as many other groups, including the department and CDC, et cetera, really reduced that. We have even the playing field with the 2 doses of the vaccine, primarily relying on the messenger RNA as clearly the best vaccine available. But we again fallen behind on the third dose, which you now learn is really essential to maintaining the protection against hospitalization, severe disease, and death. Rural Americans and those with less education are less likely to receive vaccines, and I think you're all aware of the political divide that unfortunately has emerged on this. So I would conclude that there's really been very little change since the commentary. NIH response in part was related to RADx-UP. I know that there are several awards in the New York area. We stood up this program on the will of Dr. Collins. He supplemental appropriations in 2020 gave NIH over $1 billion to develop new technology for testing. That has happened. All of those over-the-counter tests that you are using or have used were primarily driven by work that NIBIB, the Biomedical Engineering Institute, generated through a funnel of innovation. It's been remarkable what they were able to accomplish. Dr. Collins allocated $500 million for addressing disparities, and we created the RADx-UP, our Underserved Populations Program, to really focus on community engagement as the starting point and promote testing. The appropriation, we have to stay within the lane of the appropriations. So there's over 120 studies that have been funded. We go from Hawaii to Puerto Rico. Many of these were done through supplements of existing grants that already work, had established community engagement relationships. 10 of these studies are primarily focused on American Indian and Alaska Native populations. We funded a large coordination and data collection center at Duke UNC, which has been a tremendous benefit to us at NIMHD to move this along. I co-chair this whole program with Dr. Richard Hodis of National Institute on Aging, and my deputy, Monica Webb-Hooper, is the co-lead with now Wilson Compton from the deputy at NIDA. These are just a snapshot of the dimension of where we are. They are publishing. They have also an agreement with AJPH to do a special issue. They already have, I think, 18 papers that have been submitted to the coordinating center to be considered for AJPH. And you can get a sense of the dimension of this. I think the actual number of participants actually consented and surveyed is closer to 110,000, but there is about 1 million or so participants, quote unquote participants, that have been abstracted from electronic health records. So this is by far the largest program NIMHD has ever been involved in. And I think we'll be learning a lot for a long time from this effort about community engagement. I mean, this is really, with all the hiccups, bumps, and challenges that involves, this is not smooth ride. Oh yeah, we just do this, we know what to do. We know what to do, but it really varies by community and by site and by investigator. The other program we've been fortunate to be part of is SEAL. It has a very different lineage. It came out of the Moderna vaccine trial. It was actually on July 4th, a Saturday, that Dr. Collins called us to a meeting. 2020 was like that for us at NIH. And he said, the Moderna trial has started and 90% of their volunteers are white. We have to do something about that. So over the course of the next month, we mobilized all our assets that were funded by NIH, many NIMHD, but also NHLBI and others, call them to action and say, we need to do something. We don't know what and how much money there'll be, but we've got to get everybody mobilized. And that was the first group of teams. We focused on the Southeast. You remember the summer of 2020, that's where the pandemic was surging. And we included the Southwest because that's also being affected, particularly Southern California and Arizona. Subsequently, we expanded SEAL to 10 additional sites. Sorry. Oops. So we have 21 teams now in the field. The Community Engage Alliance Against COVID-19 was built on community engagement, partnerships with community-based organizations in these areas. It includes rural areas, American Indian, Alaska Natives, Asian Americans, Pacific Islanders, Native Hawaiians. We are in Puerto Rico. African Americans and Latinos were the main focus initially, but it is a broad swath and a number of non-funded, so we created experts, a steering committee, inclusive participation committee, and a needs assessment committee led by national leaders who are not part of the teams. And I think this has been a very productive. There is uncertainty about future funding. The budget being discussed now in Congress does have resources for us, and we're very grateful to the congressional support. But clearly, creating this kind of community-based infrastructure takes time and resources. So our goals really are to understand these factors, how we can best serve underserved communities, to support community-engaged strategies, to address the gross and malevolent misinformation that has been generated. We lost that battle on communication in this pandemic. We thought, we meaning NIH, we produced this vaccine. It's incredibly efficacious, at least short term, and long term, it clearly is still beneficial. We thought people would just come and get it because the pandemic was so horrible. A bunch of people did, but a bunch of people said no. And this mistrust in science has been unfortunately ingrained now in much of the community. So mandates are not acceptable to the United States population in general. So we need to persist in gradual persuasion, much like we have in other areas. And this is a long haul. And I say this because it's not going to be, it's not done with COVID-19. If we phase out of the pandemic area into an endemic, as it looks like it's heading that way. So this promoting this awareness, trust, access, inclusion, moving at the speed of trust has been our mantra, is really, really important. I would say that that this was an underestimate from all of us. And I think how we do better in communication science, how we do better to address misinformation will be a priority for us going forward. SEAL has made a huge effort in communication. We've been less about doing science like RADx, UP, interventions for testing, than just let's get the word out there. And you can get a sense, with over 2 billion views of our materials. Lisa Cooper, known to many of you, is one of our co-chair. Ricardo Munoz has been the other from UCSF. And Gary Gibbons, NHLBI has really been the lead institute on this because of their resources and the mechanisms that they have available. But I've been there with Gary every step of the way with full support from Dr. Collins and Dr. Tabak and all of our IC director colleagues. I've particularly leveraged my fluency in Spanish. I did some of this, a moderate amount of this in San Francisco at one point in my career, particularly around smoking cessation, but Telemundo, Univision, and a variety of radio mornings where I would do half a dozen to 10 live or recorded interviews with different radio outlets across the country, all in Spanish. And this has kind of slowed down recently. I would get a request to do something the next morning, usually from the White House. I did them while I was visiting my wife's family in Argentina, while I was on leave in San Francisco, and certainly on the East Coast time. Let me wind down with a few comments about other topics. So talking about racism has never been part of polite cocktail party conversation, right? And I know that for the most part, people never wanted to bring this up because the immediate reaction was that people would feel accused. 2020 changed that. Racism, discrimination has been part of our mission and central to the issues of disparities from the very beginning. And this is not a slide I made up in 2020. This is something we were using almost all my talks on global issues in NIMHD. These are data from the Kaiser Family Foundation. They do national surveys, population-based, asking in the past 30 days, were you treated unfairly because of racial or ethnic background in a variety of settings? And this is from 2015. Over half of African Americans said yes, and over a third of Latinos said yes. And this is astounding. And this is 2015. So we do better in healthcare as we should, but we have a problem. And I think right now, the 2020 event sort of brought this to a head, and everyone thought, well, we've turned the page on this. Well, we haven't. There's a counter effort now to bury this, as you're aware. Again, this is not a short-term issue. This has been long-standing structural factors, and we've begun to make some efforts from the NIH perspective in research. But I think up and down, all of our institutions need to address this in a directive way. Looking at racism discrimination as a research construct, we categorize, I created this sort of categorization. So interpersonal is what we mostly have focused on. Almost all the work has been done there. There are really excellent measures, the Everyday Discrimination Scale and others. They're on a Phoenix website. There are very robust associations established with mental health outcomes, behavioral outcomes, substance use outcomes in adults and adolescents. Less clear associations with long-term outcomes, although some with cardiovascular, particularly around blood pressure and stress. Internalized racism refers to persons who say, no, I've never been discriminating, I don't have any, but they have somehow sublimated this either culturally or biologically. And biological measures are looking at things like allostatic load or cardiovascular reactivity or telomere length and others. Cognitively would be this sort of sense of being inferior and just adapting to that. And this is not that uncommon. Again, hard to study. The perceived societal discrimination is a very clever or important, I should say, innovative approach done with adolescents by investigators that I first saw this from Southern California, asking adolescents about. So rather than your experience, they said, what's society like? And it was clear the robust associations with mental health and behavioral outcomes in substance use in a cohort 1-year follow-up study of high school students in Southern California, a very diverse sample of students in Los Angeles. And then secondhand effects is, I think, very understudied. What's it like to be living with someone or being under the same household as someone who's been a victim of discrimination, racism? Maybe they're not aware of it. And I think this is, again, from the tobacco literature, we talk about secondhand smoke effects, so secondhand effects of racism. But it's structural racism that has come under light. This history, culture, institutions, policies that codify this inequity, built partly or large part on the residential segregation policy as a cornerstone of this system. And we are paying the consequences of this today. Keep in mind, this was designed in the 1930s. It was intentionally designed to keep initially African Americans in their place. Post-World War II, as the American economy took off on a domestic basis, the redlining approach to loaning funds for banks loaning money for people to buy homes sort of perpetuated this inequity for Black communities and subsequently Latino communities. Most US cities are very segregated, and the redlining was literally that. We can get from historical documents. And yes, that was made illegal a long time ago in the 1960s, but the consequences are being experienced today, as was recently demonstrated by exposure to contamination, air pollution from power plants, proximity to freeways, and car exhaust. And as I mentioned before, access to full-service supermarkets, even in wealthy cities like San Francisco. And this is an area that needs to be acknowledged as important, and how we go about not just studying it, but also really doing some interventions to address it. How do we create healthy communities to address this? And this is a huge challenge. Most people have measured this using population metrics from the census or the American Community Survey combined. The CDC has a social vulnerability index. It does use race, ethnicity as one of the measures. But I recently learned from a presentation from a Federal Qualified Health Center network called OCHN, if you're not familiar with. They're based in Oregon, that 40% of their patients, if you look at only population metrics, were misclassified as not being underserved when they actually were when you collected primary data from them. So there are limitations to these population metrics in research. So we are focused on studying this. We held a workshop in 2017. We have a RFA that was published. We will be making, I've already made funding decisions on initial set of grants that will be funded under this RFA. I trust other institutes as well. Once our budget is finalized, we may add some additional ones. I don't know if we'll get to 20 or 30 R1s from this response, but we'll see as the other ICs make their decision. And there is an ongoing common fund initiative in process called COMPASS. Shannon Zank, Josh Gordon from NIMH, myself, Janine Clayton from Office of Research and Women's Health, and Dave Wilson from the Tribal Health Research Office are co-leading this. The concept was cleared in the Council of Councils, and we will be developing this call for funding in fiscal year 23. The NIH has committed $400 million over 10 years to address interventions to reduce structural racism. This is a summary of the facts around COMPASS, the structural drivers being upstream, and how we need to do this using community-driven, rigorous research to achieve health equity. Some broad examples of research that has been done on this, probably too scattered here to emphasize any particular one. Moving to opportunity is one that is well known. This is where usually single parent, led by a woman households were provided with vouchers to rent homes outside of the lowest income neighborhoods. It's a randomized study done in 6 urban centers, six cities in the US. And if it was done by HUD. It wasn't something NIH, but NIH tagged on with it. And it had health outcome benefits, lower BMI, lower hemoglobin A1C. And the children who were pre-adolescent when they moved did much better, but the adolescent boys had worse outcomes. So these are the kinds of studies that we need to begin to do. We need to focus on how we work with other agencies in government and other organizations locally, and not just keep it to academic health centers and researchers. So how might we mitigate racism? These are some ideas of mine. Clearly, early childhood education, supportive parenting, all these things that are good in general for your health are going to be good to mitigate racism. The integration experiment that this country went through in the 60s and 70s was actually working. If you look at the macro data, it continuously better between 1960 and 1980, began to deteriorate in 1980, and did not begin to recover until the late 1990s. So this is something to consider of how we recapture some of this. Promoting social cohesion, better interpersonal interactions, issues around religiosity, spirituality, meditation, mindfulness as interventions that help. I do think that the patient-centered medical home, a good healthcare system also has a major role to play here, and then addressing the institutions. Back to healthcare, I think the patient-clinician communication is a central issue. I'm very much bonded to this. I do think that we have an opportunity to make a difference. Yes, one patient at a time, but this can be magnified tremendously in the people who are most vulnerable with chronic disease. Lisa Cooper did elegant studies showing race concordant visits were more patient-centered. We've done work with concordance in language. And yet, as I mentioned earlier, if you look at what physicians do, this is from the Medical Expenditure Panel Survey funded by HRQ, the African-American and Latino physicians care for over half of the minority patients in that cohort, and over 70% who have limited English proficiency, and disproportionately more uninsured or Medicaid insured patients. So I think this is an intervention that works. So to train more physicians, clinicians from these populations, yet we're not doing it. And in fact, there are legal barriers that are going to be increasingly challenging to overcome. I want to emphasize that the theme of diversity in science is not, to quote my friend David Williams, not a snowflake approach. Oh, we're all different. There's something to learn from everybody. Let me taste your food, learn about your history, your culture. That's all good. Don't get me wrong. I value diversity. I love to learn about new areas and new people. And certainly Brooklyn or San Francisco, or for that matter, the District of Columbia are great examples of where that is. But it's really addressing equal inclusion of people from all backgrounds, though, especially those who have been viewed differently because of exclusionary practices. And we have that well identified from our history and our practices in the 20th century and before. In the healthcare setting, we start with expanding access. The ACA experiment has been effective. It's imperfect, but it has been effective. And I think going forward, we need to identify ways to make it stronger. Again, implement what we know what to do. Public health consensus. Let's go make sure that the groups that are most affected by this are targeted. There are many ways of coordinating system. There's lots of data on the role of peer navigators or expert navigators in cancer screening or in changing community norms. I think we need to implement those more systematically in healthcare system with our sickest patients or our patients who are clearly utilizing healthcare in a different way. I'm a strong endorser of primary care. Our healthcare system has been turned upside down. We only graduate a third of our medical students go into primary care disciplines, and even a good number of those don't end up doing it. This is a flaw. It's much more lucrative to be a dermatologist or a surgeon, ophthalmologist, than to do family medicine or general pediatrics, and that's just wrong. And we need to even that playing field there. This is a policy issue that needs to be addressed. The EHR has been a sea change for healthcare. I lived through that transformation. Nobody liked it, but it is better care. And now we need to look at it and make sure it does address equity. And I think I'm hoping that CMMI and CMS will create some sort of equity quality measure that our hospitals and systems will need to address. And then back to community engagement. It starts with equal partnership. The scientists need to, roll up their sleeves and go to the community. That's the way things are. People need to see you. They need to see us. And we need to be there shoulder to shoulder with the organizations. We need to shift our models of care, as I mentioned. And I think we need to emphasize the importance of health, not just healthcare. As my colleague Sandro Galea would like to say, if we were a football team, a soccer team, we could say we have a wonderful goalie. We can stop. We take care of the sickest people better than any place else in the world, but we're not taking care of the health of our communities. If you look at our macro statistics on infant mortality, maternal mortality, morbidity, deaths from a variety of conditions, with perhaps the exception of tobacco control, we are worse off than almost every other high-income country in the world, and in fact, some middle-income countries as well. So engaging community resources to promote health is a central part of this, and part of this means dealing with structural and interpersonal racism. So I'll stop my slides. I probably went on too long, so I'm sorry, but I'm happy to stay as long as you would like or have room for on your agenda to answer questions. Thank you very much.
Thank you, Eliseo. And it's exciting to hear about the initiatives at NIH that are directly addressing systemic racism and structural racism. So I think I'm sure my colleagues are all excited about what you've discussed during your presentation. We're a little bit behind, so I'm going to just go through the earlier questions in the chat and take maybe two questions. we had a question asked earlier about disability and determining health. That, you know, people who have disabilities obviously also experience, perhaps in a more severe way, social determinants of health. Can you comment on that, or how NIH approaches that line of work or research?
Absolutely, yes. This is a current issue that is beginning a discussion. So the spectrum of disability is quite broad, and up to, I don't know, 20% of Americans could be categorized as having disability. Most of the research has been housed in the National Institute of Child Health Development and Development because of the issue of children with cognitive or physical disabilities, and of course, many of them now are surviving in adulthood, and their portfolio is quite robust there. But the spectrum is broad. We actually have funded a number of grants, and I didn't mention, but in the RADx UP initiative, two of the school-based projects are basically focused exclusively on children with cognitive or physical disabilities in school districts, and also they're targeted in our regular RADx UP program as a medically vulnerable, socially vulnerable population. So no shying away from research on this. And I think like other conditions, for example, I think the one I think that I would call out is persons with severe mental disorders. They're 5, 6, 7% of the US population. And by that, I mean people with severe bipolar disease, people with chronic schizophrenia, chronic psychosis. They live 20 years less than their age adjusted counterparts. And they don't die from suicide. They die from cardiovascular disease related to sometimes the drugs we give them, sometimes their lifestyle, or some combination thereof. And so there are clearly major disparities. And you could name just about any chronic disease or cancer survivors, and life expectancy is reduced, and there is disparities that are existing there. So very much acknowledge this as an important. I think the differential from what we call disparity, population with health disparities, is the fact that these are conditions as opposed to demographic or identity factors. And I think where I would differentiate those two, and maybe create more of a category of conditions, which are many, where there is medical vulnerability or medical conditions that clearly lead to worse outcomes. So that's my current thinking on this, but this is an evolving topic, and much more will be considered and reflected on in the coming years.
Okay, thank you. And what about your thoughts or whether there are any specific initiatives on the idea of intersectionality at the NIH? So the chat question had, consider intersectionality, for example, an older Black woman who has a spinal cord injury. We have here one individual who is part of 4 minority groups and suffers an inordinate amount of barriers to quality of life. So I think it's sort of similar to what you're saying, sort of creating a sort of a category that's medically vulnerable, but on top of that, there are other group membership that makes this individual vulnerable. Right.
Intersectionality is come to the forefront now several years ago, and if you look at we withdrew from the parent R21 program because I really was worried people were submitting R21s because they were afraid to submit R1s, and they should be submitting R1s. And the funding rates were much lower for R21s, by the way. And then we published our own R21, and one of the topics that we address here is do methodological work, as well as secondary data analysis and pilot studies for interventions. I think we have published interest in intersectionality. I think if you have the sample to be able to address this, then by all means do it and address it in your research. So clearly, I think there are a number of projects that evaluate, what's the role of race, ethnicity, what's the role of sexual orientation or gender identity, how do those intersect? And that's been where I think we've had the most work, referring to, in the case of people with physical or cognitive disabilities, under the rubric of, well, what about those who are racial and ethnic minorities? How do they fare in that context? And yes, that's precisely where the NMHD interest should be in those conditions, and that's what we would emphasize. So it's an important approach to the problem that needs to be studied. I think the challenge is you need to either sample deeply into a smaller population, otherwise you'll be stuck with very small sample size cells. And I think that it depends on the question on the investigator and what's the data in the topic and what the best approach is. So, and we often don't measure, I mean, do we measure that routinely in large data sets? No. So frequently you're stuck with going out and doing your own data collection. So.
Thank you. And then finally, I have a question from Simone Seward. How can academic medical centers incentivize medical students to go into primary care, especially when they incur a tremendous amount of debt, specifically underrepresented minority students?
Well, thank you for that question. That's really in the policy arena. I think it would take major reform of the profession. Perhaps salary would be one way to do it, although you'll hear a lot of screaming. Why does an ophthalmologist, and I don't mean to beat up on ophthalmologists at all, get paid on the RVU method the same amount for 20-minute cataract extraction, a clearly beneficial intervention? They would get 17 or 18 RVUs, and a generalist seeing a complex patient with multiple chronic diseases and maybe some disability or psychiatric problems, a 40-minute new patient visit will get maybe 3 RVUs. And when you have that kind of inequity in reimbursement, you're bound to drive trainees to the high reward, narrow area of expertise, and better lifestyle, quote unquote, disciplines. And that's just not good policy. We live in a market system, so we have to figure out how to do this in a market way. And the United States has defaulted on this. We know it can be done, that you can make it sort of a more even playing field. The UK has done it fairly well. It's really approaching it population based. Now, incentivizing students, I'll just mention one study. I was part of. A medical student approached me and said, "We want to study this question," and we got data from the AAMC for 3 years. They do an annual survey of their senior students. It's anonymous and de-identified, but they have the demographic factors, including loan debt at the time of graduation. And in that analysis over 3 years, medical students graduating from underrepresented groups, and we were able to include Southeast Asians and Pacific Islanders, Native Hawaiians into the underrepresented group in that analysis, were twice as likely to intend to practice in underserved areas, regardless of their specialty orientation, compared to non-underrepresented Asians and whites. After adjusting both for gender, because women we know are more likely to do that, so we already knew that, and after adjusting for interest in primary care, which we also, people who are interested in primary care are more likely to want to be in underserved areas, and loan debt. And these young people had over $200,000 on average in debt when they left medical school. Now, in the research arena, we have an intervention that works. It's known in the world as cash assistance interventions. In NIH, we call it the loan repayment program. We're in the midst of trying to do a more detailed, rigorous analysis, but in initial view, loan repayment keeps scientists in research, and by our own NMHD analysis of our own recipients, more likely to obtain any kind of NIH grant and more likely to get an R01 grant than the comparison group of people who didn't get the loan repayment, but which of course there's some self-selection there, but clearly this is a program I would continue to sustain and expand if possible, and it has been expanded as a way to keep scientists in research, and particularly beneficial underrepresented groups. Because in MHD, about 60% of our loan repayment recipients are from underrepresented racial and ethnic groups. And another group is less privileged socioeconomic status in any science. So we fund people interested in minority health disparities, but also there's a special part of our loan repayment program that's for any scientists who are socioeconomically disadvantaged. That was by the legislation. So I'm very, very proud of those accomplishments and look for ways to expand it if and when our budget grows. So.
Excellent. Yes, we have a comment from one of our faculty that it works. The LRP works. So she's part of it. So, I think we all want to have more conversation with you, Eliseo, but we're way behind. So I'm going to have to, I don't think I'm going to take, unless there's any pressing questions, I think we can move ahead to the next panel. And you are welcome to join us. I think it would be great also if you were, you don't have to stay the whole time, but we have the final panel is on sustainability and capacity building. It would be great to have you there, but we understand that your time is limited.
Well, I can stay on. I apologize for taking so long. I just got in, I have that flaw. I talk too much. And I didn't see your chat telling me to wrap up. when you're on Zoom, it's just
I know it's overwhelming. So, but yeah, we welcome you to join as long as you can.
Thank you, and it was it was wonderful to be here with you this morning. Take care. Bye-bye.
Bye-bye.
Okay, thank you, everyone. We are now transitioning to panel 1 on what is community engagement and the evolution of community engagement in healthcare. Our next panel moderator is Dr. Azure Thompson. She is the assistant professor in the Department of Community Health Sciences, the School of Public Health at Downstate Health Sciences University. We also will have our discussant, Dr. Adibonye Jumbo. She's also an assistant professor and clinical coordinator in the Medical Informatics Program and a presiding officer of the School of Health Professions at SUNY Downstate Health Sciences University. Thank you, Dr. Thompson, the floor is yours.
Good morning. I'm really excited to moderate this panel today. I just wanted to give you an overview of what we're going to do. I'm going to do some very brief introductions, so names and affiliations, and then the panelists are going to provide more in-depth introductions of themselves. We'll have panel moderator questions and panel discussion, and then time for questions and answers, and then discussant or a brief summary of what we discuss in the panel. So my introductions are also going to be the order in which panelists will introduce themselves. Okay, so first we have Derek Griffith from Georgetown University. And then we'll have Barbara Israel from University of Michigan and Angela Reyes from the Detroit Hispanic Development Corporation. They have been partners in community engaged research and will be presenting together. And then finally, we'll have our own Downstate School of Public Health, Thomas Mackey. So with that, Derek Griffith, please introduce yourself.
Hey, good morning, and thank you very kindly for inviting me to be here with you. It's a pleasure to be here with you. My work has largely been, I was fortunate to be trained by a lot of I'll call them godmothers of CVPR, both from the community side as well as from the academic side. And so I'm going to bring that to certainly the conversation. But actually where I want to start with my remarks is really thinking about some of the populations that have been adversely affected by COVID, and to the earlier comment in the chat about intersectionality, I really want to focus on the disproportionate rates of mortality on Black men from COVID. And so thinking about that as one of the issues that COVID, part of our panel was not just about the evolution of community engagement, but also thinking about what are the lessons learned from COVID. That one of the lessons learned is that we're continuing to face populations that are disproportionately affected by something that is supposed to affect everybody equally. And, today, as I brought, is kind of a dubious anniversary, if you will. Today is the second anniversary of when Rudy Gobert, the basketball player, was diagnosed with COVID, and that actually shut down the NBA, and then really led to a lot of the challenges, a lot of the closing of the NBA season, a lot of the policies that closed down and changed how we sort of operated in indoor facilities and so forth, and really, led to sort of a sea change in sort of how we operated in that space. We know that if you look at mortality between 2019 and 2020, that Black men had the second largest sort of decline in life expectancy between 2019 and 2020 of 3.3 years, when typically only surpassed by Latino or Hispanic males of 3.7 years. And COVID in that time period was the third leading cause of death, only surpassed by heart disease and cancer. And so there was a really great article about a year and change ago about how COVID hollowed out a generation of Black men and really focused on this idea of John Henryism and these idea that, for lack of a better way of saying it, that these Black men who were very important foundations of their community, that we essentially gutted, if for lack of a nicer way of saying it, the community and that important sort of pillar of the community, that these hardworking, ambitious men who were trying to be assets to their community, trying to be assets to their families and so forth, that's who we lost. And so when you think about the disproportionate mortality, we know that a lot of the mortality was not just in older adults, but it was actually also in middle age, that those are the folks that we lost. So that's kind of where I want to start to lift up this conversation. Thank you.
Thank you. And Barbara Israel and Angie Reyes.
Thank you so much, Azur, and thank you all for the panel, being part of the panel. I'm going to share screen. Angie and I have a few slides that we would like to share as part of our opening comments. Okay, is everybody able to see these? Somebody give me a head nod. Yep. Okay, terrific. Thank you so much. So again, I'm Barbara Israel, a faculty member at the School of Public Health at the University of Michigan, and I direct the Detroit Urban Research Center, in which we're going to be saying a few words about today. And I'm particularly delighted to be co-presenting with my friend and colleague, Angie Reyes, who will say more about herself when she gets started. We wanted to start where we were asked to sort of give our overview, if you will, of how we do community, what we mean by community engaged research and how we do it. This is going to be not new for a lot of folks. There's a lot of different ways and language that's used. That's part of the point we want to share. But want to go over some key elements of the work and the way that we do work together, which we refer to as community-based participatory research. It's a partnership approach to research that equitably involves all partners in all aspects of the research process. So the emphasis here is on equity in the partnership process. It enables all partners to contribute their expertise with shared responsibility, power, and ownership. Again, the emphasis being shared ownership, shared power, shared decision-making throughout the process. It enhances understanding of a given phenomenon. Yes, it is research. It's about gaining understanding, knowledge, and contributing to a body of knowledge, but also about integrating that knowledge gained with interventions, policy change. It's fundamentally about social change. It's about trying to both understand and address health inequities. I'm going to say a few words about a few of the key principles of CVPR. It builds on community strengths and resources. As we know, we often spend a lot of our time studying all the problems and issues and deficits that communities face. And CVPR really lifts up and acknowledges community strengths, community-based organizations, faith-based organizations, families, and the resources that exist in communities that are able to come together and address some of the issues that they also face. It promotes collaborative and equitable partnerships, sharing power and resources among all partners. I can't say enough about this emphasis on equity and power sharing. As researchers, as academics, we recognize that we're in a position with greater power than our community partners, often coming from institutions with more resources, et cetera, and really need to pay attention on a day-to-day basis of what those differences are and how do you strive to achieve equitable power sharing. facilitates co-learning and capacity building. Importantly here, this is not just capacity building of communities, which we often hear about, but the idea that as researchers, I know something about collecting data, the science of research, et cetera, but I don't know what it's like to live in Southwest Detroit, which is where Angie's from. And that's where I can gain and benefit from her knowledge, her expertise. And I don't know how to run a community-based organization. And I've learned so much from my community partners about organizational capacity and running organizations. It balances research and action for mutual benefit of all partners. So the emphasis is, yes, again, it's about research, but as our community partners always say to us, community is not about research. Community is about change. Community is about action. But how do we conduct and collect research, gain research findings to inform action? It addresses issues of race and ethnicity, racism, social class, and embraces cultural humility. It disseminates findings to all partners and involves them in the dissemination process. Today being a good example, I try to never present on our work without co-presenting with one of my Detroit partners. And it promotes a long-term process and commitment. It's not just about a 5-year R01 study, if you will, but really developing that trust and relationships on an ongoing basis and continuing to work together to bring about change. Now, I'd be delighted to turn it over to Angie now.
Thank you, Barbara. And as Barbara mentioned, I am one of the community partners as a member of the Detroit Urban Research Center. I'm actually one of the founding board members, and I'm also the founder and executive director of a community-based organization in the Latino community of Detroit, the Detroit Hispanic Development Corporation. So continuing here about the application of CBPR, we talk about it as an approach towards research. It is not a specific method or research design. There are multiple ways that you can do CBPR. Many times there's qualitative and qualitative methods that you can use and multiple designs. And frequently we use mixed methods in many of our research approaches. So again, it's an approach, not necessarily a specific method. So here we talk a little bit differently about the term community engaged research. I know that in the conference, it's used here as an overarching framework for involving community and research. Here we use it a little bit differently in our continuum that we developed about 15 years ago, looking at the dynamics between academic and community partners in research, particularly looking at the issues of power and control, who has responsibility and ownership over the research as well as the data, what's the level of participation and influence over the entire research process. So you can see on the left side or the low end of community involvement is really practitioner-driven research. Bench research, many times there's no involvement at all of community or very minimal. Community engaged research is kind of somewhere in the middle. Community-based participatory research is next on that continuum where there is an equal balance of power, control, and ownership between the academic and community members. And then all the way to the right is community-driven research, where you have many community entities and organizations that might have the capacity within their organization to conduct their own research, or in some cases to subcontract with a researcher at an academic institution to conduct the research for them. Just a little bit about the Detroit Urban Research Center. We are now in our 27th year of partnership. So Barbara and I started this, we were two people that started this when we were teenagers. We've been working together for a very long time. We've become very good friends, as you can tell, over 27 years. It is a partnership that includes the University of Michigan School of Public Health, as well as social work and nursing. And then on some projects, we also include some of the other schools like business and technology and policy. Also includes 8 community-based organizations, as well as a couple of health systems that are part of the partnership that has been working together. And just a real quick history again, we were started in 1995 when the CDC issued an RFQ for 3 urban research centers in the US conducting community-based participatory research. That was our initial funding. We have been working on a number of different issues since that time, focused on health equity. So our goals are inclusive of promoting and enhancing the capacity for both community and academics to conduct CBPR and helping to develop those partnerships, really enhancing their capacity to promote it within institutions as well as in the community. So we've been conducting a number of trainings as well for both community and academic members and partnerships. And then using the research that we've been conducting to advance policy advocacy that promotes health equity and translating those research findings to promote policy change. So we do not conduct research for research's sake. It's used to develop interventions and most importantly, to promote policy and systemic change and addressing equities. The Detroit University is, we consider it kind of an umbrella entity. We have several affiliated partnerships. We've developed over 40 over the past 27 years. They've changed over time depending on what the community's needs and issues are that are rising. Like for instance, right now we have one of the SEAL grants with the MySEAL. All of these partnerships also use CBPR and have a steering committee consisting of both community and academic partners. Some of the community partners and members are the same as on the URC board. And then we add new partners to the different initiatives depending on what the topic is. And that's it. Thank you.
Thank you. And our final introduction will be from Tom Mackey.
Great, and thank you. I'm just going to share my screen. Are you all seeing the correct screen, or is this the? Let me just make sure. There we go. I'll fix it. Great. So I appreciate the opportunity to be. I'm going to just end slideshow. Come back in. Sorry about that. I appreciate the opportunity to be here today. I'll say that this is really an area that I'm really committed to. I was a Peace Corps volunteer coming out of my undergraduate and was doing community-based work in sub-Saharan Africa. And so as I came into academia and being a researcher with a pretty classic, I'm trained as a health services researcher, a medical sociologist. I was always interested in thinking about ways to engage community members broadly defined in the research that we were doing. So I'll speak a little bit to that from the orientation of a health services researcher, which is a slightly different orientation, perhaps than might, offers another viewpoint on community engagement from the work that we've been doing. So my research agenda predominantly looks at national, state, and system level policies and programmatic innovations that are trying to improve access to quality mental health care. So we're often trying to look at research questions around innovations that are happening across public sector delivery systems to improve the mental health care system for children, adolescents, and their caregivers. And today we were asked kind of to talk about how we engage communities in the work that we do. So I'm going to broadly situate our work and then give an example of how we're doing this in the research that we're conducting. For our team, we often are thinking of community as being a set of individuals that have a vested interest in the issue at the relevant level of intervention. So much of our work is at the national level. And so we work with national advocacy organizations, for example, that are representing the interests of individuals with lived experience. They may be advocacy organizations as professional societies as well, right? They represent the interests of the providers and the provider communities that serve those individuals. So we are often looking at community at actually a different level of intervention than I think we may, or different level than we may often think about it when we think about community-based research. And so we also are thinking about engagement of these communities across our research phases. So from planning the studies to conducting them, and then to, this used to say disseminate, but we like to try to use language that's more accessible to all members of our research team and partners. So we change it to share, right? But from planning to sharing the research findings that our team has generated. And I'm going to provide just a quick example. So one area of work that we're currently doing a very large scale effort that's funded by the Patient-Centered Outcomes Research Institute is around addressing the perinatal mood and anxiety crisis in this country, particularly among Black and Indigenous individuals. And we've been doing research funded from PCORI off of a main award, so Improving Healthcare Systems portfolio grant or contract. But we've been doing a larger study. And when we were doing that study, we had our advisory board. We have a 42-member advisory board for that study. And what they had said to us is, who's not at the table here? You know, you're missing a critical part of the community that are affected by these issues. And we really would like to see more representation of the diversity of individuals and the advocacy organizations that represent those individuals who are Black and Indigenous and perinatal individuals of color. And so, you know, we quickly took a moment and thought, wow, that's actually a really critically important point. And yet in this 42-member advisory council, you know, we've assembled it with representation, but not with a singular focus on trying to advance the agenda for perinatal individuals of color. So, you know, our advisory board really identified the need for resources to build the capacity of community members and researchers to partner in planning, conduct, and disseminate studies like the one we were conducting. And rather than have it, you know, we did diversify our membership to that advisory board for the parent study, but we also thought we really needed to do a concentrated effort to advance this issue, that it wasn't going to be enough just to diversify our current board and councils. And so we partnered with Karen Tabdina, who is a perinatal mental health equity researcher, and submitted a proposal for an engagement award to PCORI called Charting the Course for Patient-Centered Research to Address Inequities in Perinatal Mental Health and Maternal Mortality. And we did that in collaboration with Lifeline for Moms, which is a national network of perinatal psychiatry access programs. So again, sharing a national focus, as our research has a national focus, and Postpartum Support International, which is a national advocacy organization for perinatal individuals for individuals who have lived experience with perinatal mood and anxiety disorders. So we created this collaboration with existing partners that we had already engaged in a number of projects that we were currently working on. And we sought support from PCORI. This is the Patient-Centered Outcomes Research Institute. I only mentioned it because they're really kind of revolutionizing, I would say, health services research in many ways, in terms of really what they say is doing research differently, bringing research topics that address the questions and concerns relevant to patients, involving patients, caregivers, clinicians, and other community partners, along with researchers throughout the process. So I wanted to quickly introduce them. We ended up submitting an engagement award. They have a number of them available through their mechanisms. They come out with special calls for particular topics or areas. And you'll see the website here. And we proposed, and this is a pretty classic approach of how we do community engaged research. So I thought I would provide kind of how we structured this as an example. But we essentially proposed having 3 councils that had perinatal professionals, individuals with lived experience, and then a perinatal mental health collaborative that included federal or national level stakeholders and community members. So that included advocacy organizations like Black Mamas Matter. That includes federal agencies like SAMHSA, the Substance Abuse Mental Health Services Administration, that has a key part to play in this issue. And it includes organizations like the Center for Disease Control, as well as PCORI actually has a representative on that collaborative. And so we have these councils assembled to be able to inform the work to create this set of resources. And they each offer differing perspectives to help us progress in the field to facilitate future partnership. And our work occurs in stages where we are preparing these councils to participate in this work with us. And then conducting a set of deliverables or a set of work products coming out of the partnerships that we have through this engagement effort. And so in our efforts to prepare to participate, particular councils will receive a webinar series called the Research Fundamentals that PCORI provides on their website, and you can see a link here to it. But this is a set of resources that help to prepare potential participants in research, potential partners in research, I should say partners in research, to be a part of the partnership with us. And so this is going to be something that they'll review, but then they'll also critically evaluate it. You know, how responsive are these research fundamental webinar series to their unique context and experiences, and are they addressing some of the historic injustices that exist in research among Black, Indigenous, and other people of color. And then we then have these mental health care journey map that we're going to be working with them to generate. And this is really to kind of create an understanding of what the experiences are of both the perinatal professionals and the individuals with lived experience. And we're working with an illustrator who will be a part of that group with us in illustrating. And this is an example of my colleague Karen Tab-Dina and her colleagues generated this journey map from the work that they were doing, looking at looking at the challenges of rural populations and getting access to perinatal mental health care. But what you can see here is that this ends up identifying a potentially promising practice of rural access programs, which serves as the bridge to getting access to the services. And so it helps create some research prioritization based in the lived experiences of individuals and the professionals that serve them. And then I've just included here one thing that we're continuously experimenting is how to do this work well virtually, because we have national councils. We're always assembling perspectives and viewpoints, and we've moved to using things like Jamboard, you know, which is almost like having a whiteboard, you know, a whiteboard or a chalkboard up, and you're putting Post-its on that, you know, and so it creates a way for us to have engagement of our entire council in real time, and with great facilitation can really magnify the participation over the course of a project rather than relying on one person to speak at a time. And so we're assembling these together into a roadmap that will be made for the field going forward. And the last thing I'll just end with is, you know, as we do this work, one thing that we've been really committed to is ensuring that we have shared principles for the way we engage communities. And there is a rubric that PCORI offers that we've used that I would say borrows from, but is not entirely, you know, it does not entirely represent community-based participatory research principles. But I reference it because it does offer one set of guiding frameworks to operate from as you do this work. And so we have a paper that we published where we looked at specific strategies that can achieve these in doing the work that we do. And I'll say that this is a critical part of our engagement work, is to constantly evaluate it and to constantly think about how we can do the work better in partnership with those that we've engaged. And the last thing that I'll conclude with is, I didn't make this explicit, but when we think about partnership, we're also thinking about it as co-investigators, right? So I had mentioned the Postpartum Support International, that national advocacy organization for perinatal individuals. They're a subcontract on this award. They're co-investigators, the equivalent of co-investigators. This isn't actually research, it's a project, but they're the equivalent of co-investigators on the research. And they're partners in every stage of our process in configuring this engagement effort. But again, it looks a bit different because the scale is different. And so we're not in a community exactly, we're in a national landscape with really diverse sets of interests needing to be represented as we advance this work. So thanks very much, appreciate it.
Thank you. Thank you. So I was going to start the panel discussion by reading a description of community engaged research, but I think I'll just highlight some things that I've heard from the panelists, because they've all done a good job of providing a description of their approach. But things like collaboration, power sharing, dissemination or sharing findings, having the research being linked to some type of action. And also, I think, which is really important, what Angie was saying about it's not a research methodology, it's an approach, and all different designs, different study designs can be used within these community-based, community engaged research approaches. So one thing I'll start the discussion with is I wanted to go deeper into this idea of what is community and how you all approach identifying communities and then engaging them. So, and I'm hearing of communities defined in different ways. So communities of identity. So for Derek, Black men, and Barbara and Angie, sounds like geography, but with largely geography, and you can correct me or expand on that. And then Tom, it sounds like it's a political or organization and advocacy, or thinking about it in that way at a different level. So Derek, can you talk more about how you define communities and identify communities to actually collaborate with or do community engaged work with?
Yeah, I think, fundamentally communities are self-defined. So it's not for me to go in and say, okay, you're part of this community, you're not. It's who the community says is part of this group or not. And so it's really sort of honoring that and starting from that standpoint. And that's part of the context of a lot of the work that goes into making sure that you're honoring the expertise of the folks in the community and deferring to them in how you understand exactly what you're going to do together and who needs to be involved in that.
Thanks. So in your work, can you describe, it sounds like part of your focus is on addressing the health of Black men. So can you describe what that might look like for you as far as, I guess, reaching out to these already defined communities?
Yeah, I mean, it varies, pretty dramatically. So it can be, thinking about men who are in a particular context. So maybe in a church-based context, maybe, again, those who are affiliated with churches, but are part of a particular network in a particular community context. They may have some, usually, the way that we've done our work is sort of a combination of setting as well as sort of geographic boundaries, but yes, there are opportunities to think about sort of looking at things in a broader context as well. But a lot of it is sort of that combination of really more social networks than necessarily geography for me, and sort of working within those networks of folks and trying to engage people who are already connected and sort of to build on that strength of the relationships, because a lot of this work, a lot of implicit in the work that we're talking about are relationships and the importance of people actually, not just being trusting, but actually demonstrating their trustworthiness. So, I mean, Barbara and Angie can tell you about all the history of how that works, but a lot of it is not just about, okay, what is your responsibility to trust somebody else, but how are you demonstrating through your the way that you operate, the way that you engage, that you're worthy of somebody else's trust. And that that's something that's easily broken and easily ruined, as opposed to something that, and you have to constantly demonstrate that and consistently do that. So I think it's really thinking about, when you're going into the community, it's thinking about those kind of things from that perspective. The quick analogy I'll use, and hopefully this won't take too long, is I'm thinking of the Chris Rock special, Tambourine. And in the special, he talks about in relationships, sometimes you sing lead, sometimes you play tambourine. And it's equally important for you to be committed to playing tambourine and being that background player and playing the drums or doing whatever it is in the background as it is for you to be out there in the lead. And in the context of these kind of relationships, in the context of my work, it's very important for you to be comfortable in certain settings. You need to be the tambourine player. You need to be rocking the crap out that tambourine, while, in other times, you may be the one who's out front, but you have to be as equally committed to being there to be the support and the person behind your community partner as you are being the one who's out in front. And so it's really about, that's kind of, some of the things implicit in what my colleagues here have already described, but it's really about, that's what we're talking about when we talk about an approach. It's really about how you do the work and how you're being self-reflective, how you're actually doing that kind of stuff. And so in identifying the communities, it's really also in finding people who are like-minded in that way and who are going to be equally committed to those kind of principles and values, to doing the work in that way together.
Thank you. Anyone else from the panel thinking about community and what is community and how you go about engaging?
Yeah, I can talk a little bit about, particularly about how to engage community, because again, as Derek had said, it really is community, how the community defines itself. But there are many different ways of engaging the community. And I'll give one example of one of our affiliated projects, Healthy Environment Partnership, that was focused on cardiovascular disease. So we used a youth photo voice project. So youth who are identified by different community partners in 3 different neighborhoods, 2 predominantly African-American, 1 predominantly Latino, where the youth were taking pictures of issues in their community that were both challenges and facilitators for cardiovascular disease. And then we had a series of town halls in each of the affected communities that were organized by the community partners, where community members were invited to come in and look at the photo voice as well as other data that was gathered, and where we presented the various issues impacting cardiovascular health. We got their ideas on how to address it, then took it to a smaller group that was larger than the steering committee, who then kind of narrowed it down, looked at best practices that some of our the student interns had gathered. And then that went to the steering committee, which consisted of both community and academic partners, to make the final decision on what those interventions were going to be and what the research was going to look like. So it was various levels of community engagement, but having those community members already at the table really helps to facilitate bringing them in, and the ways that you can do that, the messaging that goes out, how it's messaged, the languages that you use, the images that are used, all of those things really have to be looked at and decided by particularly community members to make sure that they're culturally competent, that they're effective, and they're really going to bring the community in.
Thank you. Tom?
Yeah, this is a great conversation. And, you know, we often are trying to triangulate our community around a special or shared interest, right? So, so in our work, we're often thinking about, and we do it similarly, we work with those with lived experience to define the communities, but we do that by helping bring, we often will use a taxonomy that's offered called the 7 Ps, patient and the public, providers, purchasers, payers, policymakers, product makers, and then principal investigators. And we work with our community partners to think about all of the individuals that may be relating to that particular interest, right? So in the space of perinatal mood and anxiety disorders, which I had introduced during my introduction, who are the providers, right? Just as one example, right? So we worked with Postpartum Support International, and you know, we have been historically working quite closely with clinical partners, and we're really thinking about obstetric providers. But when we worked with our community partners and thinking about who that provider community is, it expanded dramatically, right, to include doulas, community health workers, as well as spiritual leaders in the communities in which they live. And so we began, you know, we really began to work outside of what we might have had as an assumption of what, you know, the provider community was by working in partnership to define who each of these communities are within that type of taxonomy.
Thank you. I think something that was really important that Barbara and Angie brought up was this power. So, you know, you talk about power sharing. So what is that? What does that actually look like for you, Tom? Maybe you could provide, or yeah, what does power sharing or understanding of your power and being able to probably neutralize that? What does that actually look like for you, for example?
Yeah. Well, I mean, we approach our work with as much humility as we can, and so I think that that's critically important. You know, we try very much. We have relatively little mic time on our meetings. I showed the Jamboard as an example, but we really start the meetings by engaging the individuals on the council with what, you know, we agenda share. Like, they'll set the agenda for many of the meetings. Some of the meetings we will we'll have an agenda we need to meet, but we work with them on setting the agenda for each meeting. It's a collaborative process of determination of what we'll spend our time doing, and we do have governance plans that clearly state out, who makes a decision on particular aspects of the work that we do together and who informs the decision. So we sort of use a bit of the if you all know the RACI kind of framework, but we use that type of framework to be very clear about who's responsible, accountable, going to inform specific decisions that we're making as a group. So we try to facilitate as much transparency as we can, because there are some things that for informing our research, we're ultimately the ones that are going to make the decisions, but there are other aspects of the way that we operate that they'll be the ones that make the ultimate decision. And regardless of what we do, we believe in having full transparency. So after each of our councils, we actually have a feedback matrix. So we record everything that was recommended, and then what was the immediate response, and then what was the long-term impact. And we provide that at the outset of our next engagement, so that folks can see what happened between the meetings. And so those are sort of some of the systems that we put in place to kind of really facilitate a governance structure that allows for, recognizing there isn't equal power, right? But try to facilitate the transparency about where power is in particular sets of decisions, and then also accountability for being responsive to the input that our partners provide us.
Thank you. Can you talk more about that, Barbara and Angie?
Sure. I'm glad to start off, Angie, and then jump in. I mean, a couple of things that first of all, I think it's about sharing resources and information. We share the budgets. We develop budgets together. I see this as an ideal to strive for. As long as the university if the university is always the fiduciary, and if the university is always the key, receives the funding, then by definition, that's an unequal distribution of power. And so we do have examples of where some of our partnerships, the key fiduciary is the community-based organization, not the university. We also have situations, the example Angie gave before of the Youth Photo Voice project, that we did a subcontract to DHDC, and they totally ran that program. They hired the staff, they recruited the youth, et cetera, in the context of the steering committee. And, so different ways to think about sharing funding. Again, it's not always equitable. It's an ongoing thing we strive for. One other thing, and I'll turn it over to Angie, is we use a consensus decision-making approach. So all of our, we also recognize that consensus is hard, 100% consensus on everything. And so we've adopted what we refer to as the 70% consensus decision-making rule, which means that everybody has to buy into a decision. Everybody has to support it with at least 70% of their support. Whatever that means to them, it could have been 60, 80%. This is actually something we adopted from UAWGM way back when. And it has really been incredibly valuable. Sometimes we don't make a decision for several meetings because everybody can't get behind it with at least 70% of their support. But the difference being, if you do a majority vote and 70% vote yes, then that other 30% is not going to be happy. In this instance, everybody has agreed we can get behind this and want to go forward. So let me turn over to Angie and other things she might want to add.
Yeah, I just wanted to mention too that there's also power dynamics between the community partners as well too, right? So for instance, I've been a board member for 27 years, so I have to be very conscious of the fact that sometimes my voice is louder than other folks who are new. It's the organizations that are members of the Detroit URC board, not the individuals. So when there's a new executive director of an organization, they come in new into a partnership where people have been around the table for a very long time. It takes a while for them to get acclimated and find their voice. So especially lately, we've been putting some additional things into our agreements and our operating norms to make sure we're taking that into account as well too.
Thank you. Derek?
Yeah, so what struck me, and I'm going to try to step lightly because I've stepped on these landmines before, but I think one of the biggest things I want to raise up in this conversation is that usually the people who have the biggest challenge with the continuum that Angie sort of illustrated about, where we fall in this decision-making power agenda is really the academics. And that if you have people in a partnership, particularly the academics coming to the table that have different levels of understanding and willingness and commitment to where they are on that continuum, that you're going to have more problems than if you actually make sure that everybody has bought into the same definition around the same table. And that has been one of, for me, the fundamental issue. It hasn't been the community partners' willingness to buy in. And that's usually where the reason I was talking about trustworthiness versus trust is because usually we're putting so much of the onus to trust and to uphold these values on the community, when usually, frankly, the academics are usually the problem. And so we have to be, and so that's one sort of thing for me. You asked about sort of defining power. The framework that I've used for years has really been coming out of work by Stephen Lutz, who did this work, I think it was in the 70s, that you have kind of three different levels of power. One is sort of the overt, explicit sort of decision making. So who actually is making the actual decision? So Barbara and Angie were talking about the perfect example of, who sees the budget, who gets to decide what proportion of this, that, and whatever. But then there's also, as was also stated, Tom was saying, who actually sets the agenda? And that's more important than people sort of realize that, who actually gets to say what are we going to discuss? And that's a higher level, because once if you set the agenda and whatever you want to discuss is not on the agenda, then you can't make a decision or contribute to that decision. So those two levels are really important. But then the highest level is really shaping the meaning of what actually gets on the agenda and what then gets decided. And so all of those things, and that's where the shared commitment, the shared values, you saw the reason, for me, that Angie and Barbara have talked about sort of these as principles and approach and so forth, and I was talking about values, is because those things that shape the meaning of what you're doing and how you're doing it, those are what actually sort of gets filtered down through the agenda and through the decision making and so forth. So you have to start with that culture of what you're talking about, the shared values, and that constant commitment to making sure that you're walking the talk of sharing those commitment and values to that work. So that for me is the essence of the power sharing that we're talking about as it relates to CVPR.
Thank you. We do have to open it up for Q&A. But I haven't received questions yet, but I do have a final question around the future of community engaged research and approaches. Maybe we could wrap up the panel discussion with that, but how do you think about the future of community engaged research? I'll start with Tom.
Okay, great. Yeah, so I really, where I see, there are a couple of areas that I see really kind of being what we need to work on within health services research and the efforts that we do. One is actually on the back end of the engagement process, which is with regard to facilitating the dissemination of the research that we conduct, whether that is in partnership or otherwise. But I think that we really haven't. Oftentimes we think about the partnerships that we need to do to develop the research questions and to do the research as well. But the partnerships that are critical to actually making the change that's necessary to decrease that translational gap that exists between what we know and what happens, particularly among communities that have been that are marginalized and underserved. And so I think, in many ways, like I've been thinking a lot about what are ways that we can push our engagement efforts to ensure that we are facilitating the translation of the research into direct action. And that's not an easy task, right? It requires new methods and approaches. We've been doing things and thinking about approaches like simulation modeling and using system engineering principles to facilitate the integration of what we know from the evidence into the real life decisions that are confronted by community members on up to policymakers. But I think that there's a lot of work to be done in facilitating the translation, that last part of the process of getting it into action. And then I also think that there's a lot of work to be done in formalizing some methodology around facilitating partnerships in the work that we do, right? So we've been doing things like discrete choice experiments to integrate the perspective of community members into selecting outcomes. And it's a different approach than Delphi panels, which have also been used, but we need more methods like that, more of different approaches that will bring different strengths and weaknesses of really ensuring that the work that we do is infused with the voices of the community members and the partners that we have brought to the table to do this work with us. So those would be two areas.
Thank you. I'll keep on going with Angie until I see a question.
Sure. So for me, community-based participatory research is a powerful tool for the community as more and more both academics and community organizations and partners are becoming familiar with this approach where you do have that level of power and control. Being able to use that research to really make systemic change has become a very powerful tool, particularly now as we're trying to address issues around racial equity. And the community is in a different position than the academics. We have much more flexibility in terms of taking those policy recommendations and taking direct action in our communities. So for me, it's a very powerful tool for change that I hope continues to grow in both academic and community settings.
Thank you. Barbara?
Sure, just a couple of thoughts. I mean, I think one of the things, and just picking up on Dr. Perez-Table's earlier comments, is really putting additional resources into supporting infrastructure for this kind of work. I mean, just speaking for ourselves at 27 years, it's hard to maintain the work that we're doing because people like to fund new things. Understandably, but the infrastructure for training potential faculty, doctoral students, postdocs on how to do CBPR, capacity building within communities on how to do CBPR, increasing the greater diversity in the workforce for faculty and faculty of color. And again, some of the points that he was saying before, the statistics around the R01 principal investigators. Those are the kinds of things that really need to change. I mean, I'm very well aware of myself and the work that I do as a white person in a predominantly community of color. Really need colleagues who've come from the community, embedded in the communities with the academic training to be the PIs. So I think that's something that support both at the NIH kind of institutional level, but also our universities. And how do we put more emphasis within universities and funding and training, et cetera, to make some of those changes come about.
Okay, and Derek, the future, and we do have one question, so.
Yeah, so for me, the future is really going to have to grapple with how do we think about, see, community engagement is not inherently anti-racist, and it's not inherently committed to the agenda of trying to achieve health equity. Yeah. So how we're going to grapple with creating partnerships that are committed to the long-term, not just strength of their relationship, but long-term values of how we're going to deal with equity, which means that we're going to have to deal with some of the tough conversations about, if it's hard enough to engage in sort of partnership decision-making around resources in a partnership where you're actually knowing people and working together, community, health equity is going to require a distribution of resources that is going to be really difficult for people to grapple with, because it does mean that we're going to have to distribute resources based on need, not just based on, what we see as everybody getting the same thing. So the ability to sort of integrate anti-racism principles into that is going to be really fundamentally important. And as we think about efforts to address structural racism and move towards health equity, which are really kind of operating in some ways in two different directions, that it's going to be really important to think critically about how we're doing that work and how do you integrate those fundamental values. So, and the question in the chat was related to implementation science too. And so we actually just published a paper, Rachel Shelton and I and some colleagues, about anti-racist approaches to implementation science. And some of that was talking about, the need to look at things through this anti-racism lens, and how you do partnership work is part of that, how you engage with partners and so forth, to think about both your shared vision and the shared values that you have that are fundamental to the work that you're doing and how you're doing it. So I think it's really lifting those up and using that as the lens that or the litmus test that you're using to compare everything to. And I think that's one of the strengths of, from my lessons from sitting, with my mentors over the years, watching how they do it has really been the thing that's most important. When I looked at Jeannie and my main mentor, my muse, if you will, my professional muse, it really was how she did the work and how she engaged with people that really drove how I saw her success, and her, willingness to ask difficult questions, her willingness to grapple with those kind of things, and ability to deal with those kind of very uncomfortable issues around not just race, but racism. And what does that mean in the context of the partnership or the setting where you are in, say, institutional partnerships, like she's working with or has worked with, like Moses Cone Health Center and the breast cancer treatment work and so forth. Like thinking about those things in that context and dealing with the very uncomfortable things of there's something amiss here if you're seeing these very inequitable outcomes, and that racism has got to be, brought to bear in a very sort of mirror-like sort of conversation about what am I doing differently, or what am I doing that's contributing to this problem. And so CVPR can help to facilitate that, but it does mean a lot more self-reflection and a lot more humility than people have necessarily always been willing to commit to the work.
Thank you so much. I think that will be our last question.
So I'm going to jump in. Hi, this is Dr. Straker. Dr. Jumbo, do you have any comments on what the panel has presented? We are under time constraints, but I wanted to give you the opportunity to say something.
Sure. A lot has been said. From the beginning this morning, when we started with the first presenter, I was basically amazed in terms of, how we as researchers, also upcoming researchers, we can take advantage of the community engagement research approach. So that a lot had been said. Basically, the different definition and also perspective on community engagement. But one thing that I kind of, hear over and over is basically power sharing in a way to make it more transparent, in a way to engage every community members, regardless of the level of the community members, to have them have an input and feedback, on the agenda and also decision making, in a way to make it equitable for everyone, not just having the academic institution to lead this project, but also to engage every aspect of community members, from the youth to the elderly, to the disabled, to the disability folks, to everyone. So a lot has been said, and also about lived experience. Those who are actually living the experience can actually testify how they can participate and make decisions regarding their health. And as we know, systemic racism, this is also one of the talks that came out. It keeps coming out in every participation that we engage in. We need to find a way to eliminate this systemic racism to have an equitable health across the board.
Thank you, Dr. Jumbo. Now, we are scheduled to have a break at this time. And what I'd like to suggest is that we take 3 minutes of our 5 minutes and take a short break, and we will return at 10:54. What you will notice is that we're going to try to make up time as we go through the rest of the conference. And we thank you so much for your attention. We thank you so much to all of the panelists who presented so far. And this has been an exciting morning. So let's take a little break. I want to welcome everybody back. And I'd like to reintroduce Dr. Amy Afable from the School of Public Health. And I'd like to introduce our discussant, Dr. Kutsia Banu, and she is a transport scholar and Associate Medical Director for Ambulatory Care Services at Brookdale Hospital and Medical Center. So I'm turning it over to Amy.
Thank you, Dr. Straker. Thank you, Pam. Okay, so today I'm happy to briefly introduce you to the panelists in our program. We have a slight change. Dr. Adam Aponte will no longer be able to speak because of personal scheduling conflicts. But we will begin today's panel with Ngozi Moses, the Executive Director of Brooklyn Perinatal Network. And that will follow by Natasha Williams, who is Associate Professor at the Institute for Excellence in Health Equity Center for Healthful Behavior Change at the NYU Grossman School of Medicine. And then we'll have Perez Luxama, who is the Executive Director of Life of Hope. And finally, our own Dr. Christina Pardo, Vice Chair of Quality Improvement and Innovation in the Department of Obstetrics and Gynecology here at SUNY Downstate Health Sciences University. I'll have each of them give a more detailed introduction during their brief presentations. And I just want to remind all of our panelists that we're given a strict timeline to try to end at 11:35. So I just want to make sure we're all aware of that. And I also want to briefly transition to us to this new panel, which is really designed to discuss and talk about, how are we doing community engagement in practice? How are we doing it in the field? And, our panel represents really organizations that have been serving, in particular, the Brooklyn community for many years or many decades. So I'm happy to have this and moderate this panel with them. Okay, Ngozi, do you want to begin?
You're on mute.
Yeah. I'm Ngozi Moses, the Executive Director of Brooklyn Perinatal Network. BPN is an organization that was formed from a community task force about 34 going on 35 years ago that had been brought together by the Department of Health to look at infant mortality disparities in Brooklyn, particularly North and Central Brooklyn. BPN also convenes coalition. Much of what we do are done with community partners, community-based organizations that deliver social health services, as well as reaching out to clinical service sector partners and working also with faith-based and elected officials. The focus of our work is educating and informing community with respect to improving maternal and child health, coordinating efforts for access, for clients to be able to access resources, coordinating with providers for that client community communication, which is probably the most difficult piece of what we do. Educating and informing our elected officials about needs in the community, so that when they are in their places of power, controlling resources and controlling the decisions about how resources are flowed, they can learn more about what's happening on the ground in their community. We also advocate to bring and organize and mobilize to bring resources into the community, program models, actual program resources, and we partner with others to write grants for collective work. We have been the focus of collective community-based work in Brooklyn around maternal and child health. And we use the mother, the pregnant woman, the mother of an infant as an index client to really get to the family, because we know that health does not happen in a silo. We know that a mother lives in a household, and whatever the triggers are, or the barriers, the determinants, the needs are in the household, in the home will affect the child and the mother. So we look at health in a way that wherever we can get access, we start, and then we try to engage the needs of the whole family. I listened to the panel and the presenters that went before me, and I was really enthused about all that has been said about community-based organization, about community engagement, and community-based participatory research. And I want to speak from my perspective as a lived experience, from my lived experience as a community-based organization. Doing this work for over 3 decades has led me to always ask the question to distinguish between theory and practice. There's a lot of theory, there's a lot of focus on engaging community members in research. There's a two-pronged approach that particularly the COVID pandemic showed. The community-based organizations on the ground and in the trenches that really know the community very well and are the voices of the community. And so when we talk about community engagement, it's not just about engaging the client, the member, the resident in community-based participatory research, it's engaging the voices of the client as well, which is the community-based service provider to whom they come, often hold their mouthpieces, and those who understand them best in their needs. If a community member is engaged in research and is not helped to gain the capacity to speak, they'll be engaged but not say what's really on their mind. And then when they're being served and they have a comfortable, trusting relationship, you might get a different answer than they might give in a forum in which they feel that they're not equally respected, or that their voice, that they're just a number, they're there to show some engagement, but they're not really engaged. And so as you think it's community-based engagement, and you ask the question for this panel, how have we engaged the community thus far? I would say based on my lived experience, there has not been a time when an academic center reached out to my organization or the organizations that we partner to engage in any research. We might be asked to identify clients, give them stipends to do that. But on our end, on the community-based end, when we have gotten funds and we wanted to make sure we can get some results or learn something about what we were doing, we've often knocked on the doors of academics and clinical partners to ask them to partner. And that in itself has been a struggle. And throughout the presentations that were made, I was happy to hear all of the presenters talk about the different type of dynamics. The trust is a major issue. The valued partnership, valued engagement, meeting people where they are. And what the pandemic has shown us, that when the pandemic broke, the people came to us in droves. It was not about healthcare. It was about survival. It was about what they have the next day, today, and if they're sick, can they get access, and do they know where to go, and are they afraid to go? So all of the research that's being done is good. The translation of that research to inform practice and give community-based capacity with either new methods or things like that, or even funding the collaboration between community-based partners. One of the hardest things for community-based organization, we always ask to partner, we always ask to come to the table, we always ask to share our intelligence, but nobody pays us. And we have to rob the grants and the services that fund us to deliver to our participants to be able to engage in those forums. So there was some comment earlier about distributing the resources. I'm happy to hear that those conversations are happening about who gets the resources and who evaluates how it should be distributed. One of the things that I would like to leave this panel with, and the others who are yet to come and have spoken before, is that there must be a focus on community-based clinical as well as academic research bound together. Many academics and many clinical partners are sometimes asked to take on these resources on top of their jobs, and they're not properly funded. And therefore they want to rush through, and the patience is not there to give the community time to get up to speed. It's like, this is the timeline, this must be done. We're watching the numbers, we're watching the clock, but the community has to develop the capacity, whether it's clients or an organization that has never done evaluation, before they have to develop the capacity and the compensation, the resources are not there in the community-based organization. We can recruit 100 clients for you. And that's what you get, 100 clients. They'll come, they give their input, and then they're gone, and maybe you engage them in some other things. But when those clients show up again, they show up in our care, and when we don't have the capacity to and use your resource, you use the findings that you have, when they're not translated into how we operate in the community and how they can engage, it's not community-based engagement that is effective and efficient. And so for all the research that is going on, and based on the almost 35 years of experience I have, I would urge that learning from COVID and going forward, we need embedded community service networks, and we need embedded trusting partnerships with the clinical researcher, the clinical service provider, as well as the academic researcher. And most of this conference has been on the academic side, but I'm putting in a plug for resources and attention to the dynamics and the relationship that would make clinical community, clinical academic partnership work. And there's a lot of theory, but the practice is wanting.
Great, thank you, Ngozi. I was going to ask you that question about what additional insight based on your lived experience during the pandemic would you have added to the first panel? And you directly, addressed that point that, we have a fragmented system of care, and how do we move towards a shared accountability system where hospitals, healthcare providers, and community, holistically care for our population, our most vulnerable population. And I think that's an important point. I don't want to leave that. I just want to make sure we emphasize that. And I want to hear Dr. Williams' perspective next. And I think she's coming more from the research perspective, but if you could comment a little bit on that area as well, that would also be informative.
Absolutely. So good morning. I just have a few brief slides to share. And I just really wanted to extend the appreciation to the organizers for the opportunity to present and share. And then also, I wish that I could have Ms. Moses meet with me and folks at the NIH to really talk about the time that is necessary to do this work and to really do it the right way. So I'm an associate professor at NYU Grossman School of Medicine. It's really great to be here with you all today, and some amazing people who have provided mentorship and guidance to me throughout my career, including Dr. Booten Foster. So just wanted to acknowledge that. So I'm going to share with you briefly the work that we've been doing as it relates specifically to COVID-19. I think Dr. Perez talked about the RADx initiative during his presentation. But for those of you who may not be familiar with this, the goal is to increase COVID-19 testing, and it really focuses on community engagement. Community engagement is one of the core components of this initiative. In fact, it's been the first research study that I've been engaged in where AIM-1, our major focus, is building community engagement structures and sustainability. So we've tried to do this for the past 2 years since the beginning of the COVID pandemic. And on this particular initiative, we worked with residents as part of New York City Housing, which many of you know, New York City Public Housing Authority is the largest federal housing program across the country. We've trained over 10 community health workers, and these community health workers are residents of NYCHA themselves. We focus on particular neighborhoods in New York City, And the community health workers that we hired, they received their training through LaGuardia Community College. So we really tried to emphasize, how do we as a major academic medical center work with community and also work with our local publicly funded institutions to support this initiative. It's also really important, this conversation has come up throughout the day, throughout the morning, and thinking about structural racism. We were really trying to conduct community engaged research right in the heart of thinking about George Floyd, racism as a public health issue. And one of the things that we felt it was necessary to do is to not so much rely on very traditional approaches or frameworks and principles around community engagement, but really have honest dialogues and listening sessions around structural racism and what does that mean. And we thought based on that, it would be important to rethink what are our principles. So first and foremost, we wanted to acknowledge the decades of disinvestment, particularly in the communities that we were working with around COVID-19, not only thinking about trust, but what are we doing as an academic medical center to hold ourselves trustworthy, also to recognize that we are part of a healthcare system, understanding that the healthcare system is fragmented, understanding that the healthcare system is also contributing to structural racism, as well as individual experiences of racism as well. And even more importantly, perhaps with all of this that was happening, how do we continue moving forward to do no harm? We recognize what has been done, but really think about what are the processes so that we do not contribute to further harm among communities that we've been working with. So I'm just sharing here with you all briefly, this was mentioned earlier today in panel one, I believe, in terms of the work around PCORI. So we thought that it would be really important to evaluate our community engagement strategy. And we use the REST tool, the Research Engagement Survey tool, which was developed by our colleagues, Dr. Goodman, who is at NYU College of Global Public Health. This was funded through PCORI to have this tool developed, a validated tool to really ensure that community engaged frameworks are aligned with different principles from not only academic medical centers and researchers, but also on the side of community and patient representatives. So we've shared this with our 20-member community steering committee. We've centered the work around 3 community-based organizations to help develop the framework, to develop the study design, as well as the research, and also really work closely with members from these community-based organizations. So we included patient, community representatives, New York City public housing officials, the Department of Public Health and Mental Hygiene as well. And overwhelmingly, we generally received positive feedback. We shared information back to our community partners on the strengths of the partnership that was revealed to us through this evaluation process, as also areas of improvement. One of the areas that we lacked in this early phase of the initiative was a focus on social determinants of health. I think for our purposes, we were so focused on COVID that we did a poor job in really recognizing how do we embed social determinants of health in the work that we're doing. We also, at the end of each monthly meeting, we included a brief, not validated survey, but it was a brief survey because we wanted to ensure that we were providing significant time for feedback and listening, and that individuals participating in this council really felt that they were being respected and heard. These are just brief selected quotes that we've received in the evaluation that we've conducted. Generally very positive. We provided several experts from the NYU Grossman School of Medicine so that individuals in their communities could take back the information that they were learning through our partnership about the pandemic. So they were really receiving up-to-date, minute-by-minute information. They've received information from our modeling experts as well. So that information could be shared with their community partners as well. And then briefly on the next two slides, I'll just share with you what's happening now as it relates to COVID. We are really thinking about long COVID and trying to better understand the long-term effects of COVID. There's also very patient-centered approach here, thinking about the long COVID community. This initiative is funded by the National Institutes of Health. It stands for Researching COVID to Enhance Recovery. For those of you who may not be as familiar with it, we just began at NYU serving as the Clinical Science Corps. Last summer, we received feedback from patient and community representatives on the study protocol, identifying a symptom checklist that will be used for individuals who will enroll in this study as well. We have a community engagement group, a national community engagement group that includes patients as well as caregivers who are providing feedback on study design materials, as I mentioned, recruitment materials as well. And they are also working directly with their local site community advisory boards to ensure that there is ongoing communication around what's happening with this large initiative that is really global, or that's happening across the country. It includes both adults as well as pregnant participants as well. And there's also an electronic health records cohort to this initiative as well, as it is national scope. So that's the general overview about our community engagement approach, thinking about COVID-19 specifically, as well as the long-term effects of COVID. And I also just wanted to acknowledge the many partners that we've had to date on these two initiatives so far. And I'll hand it back over to you, Amy.
Thank you, Natasha. Next up, we will hear from Mr. Luxama from Life of Hope.
I think it's the morning. Good morning, everybody. And then first of all, I want to say thank you to Amy for the partnership here at Life of Hope. Again, I want to thank everybody here on the panel as well. And Dr. Adams left me by myself. I thought like gonna be 2 minutes. We're gonna share the podium, but because of that, then I had to add that happy March is the Women's Month, and then we had talking about racism, talking about discrimination, everything. We have to know in the healthcare industry as well, as you all ladies, doctors over here today, that talking about equity, and then we should talk about, that's not the topics, but again, we congratulate you, and I take the time as well to tell you, we at Life of Hope, we honor the work you do here in our community, especially in Brooklyn. And Gozi, my friends, I'm always have to say hello to my friends and Gozi over here. My name is Pervez Luxama, and here in Central Brooklyn, I don't want to talk too much about like where I went to school, but I do want to St. John's University. And my background was engineering. I went to engineering school. I had to know like what I'm doing in social services. But again, they say like sometimes you find your vocation by accident. So I guess like, coming back in Brooklyn after I graduated from St. John's University, and then see the disparity, everything the panelists, everybody before me explained that, I feel that I have to do something. And like we all say, actions are louder than words. So COVID for us is not something new. And then I know today's topic is about community engagement, and it's a review. But what we've been doing for over 15 years at Life of Hope is not a review. Is facing like the renewal issues about community engagement, what's going on in our community prior to the with COVID. And then we had to be optimistic, but again, we have not learned things new from COVID for people in our community. So I'll leave it that way. Again, my name is Pervez Luxama, the executive director of Life of Hope. We've been here for 15 years. Life of Hope was founded by my brother, Father One, who was a priest in the Brooklyn Diocese. He went to medical school, but he feel like, after medical school, it would be better to become a priest and then to serve the community, because you have a bigger platform to do so with the diocese. So in terms of the community, in terms of the work we do here in Central Brooklyn, and from the youth, from the family, and then from the community engagement and outreach, I think the work speaks for itself. And we cannot take all the credits, we cannot take all the glory, because basically what we're doing is not for accolades, it's because the partnership we established from the get-go, and then we've been mentored, and then by our partners, our relationship we develop over the years. And we have to move forward, like what basically we learn in COVID at Life of Hope. as we know it, everybody was hiding. Everybody was hiding. And as we're talking today about equity, community engagement is to who, or which organization, or which community CBOs, because it's not been for us over here in Central Booking and Booking, community engagement. It's not been like, equity has not been for us. And we have to put the thing on the table when you're talking about community engagement or talking about it. It's always like, the same stories, it's always the same players, the same people, and coming at the table, collecting data, collecting informations from us, and then they turn their back, and then you hear them again when there's another proposal out there. But again, there's some positive side. We have to say that as well. Like, there's some positive side, and during the COVID, we're able to expand our building capacity. So we used to have like, where we are right now used to be like, on campus Crystal Way, used to be like one building where we used to be share some space to do some fireworks. So during the COVID, because of the work and then the needs of the community, which has been exist for so long, Crystal Way, where the nuns and there is a campus, they have 2 buildings. So they opened the doors for us to acquire one of the buildings. So because the work was immense, the needs were there, and then the building which is the school we provide most of our services. They didn't want to open the building, so they compromised then during the COVID to give us the building next door so we can expand, because people was coming as everybody was hiding, but the people in the community who need the services, who lack of the services for so long, they were coming to us to the COVID. So that said, we're able to provide the services. As you know, like funding resources is always a lack for CBOs like ourselves. Like Ngozi was saying before that, we here on the main street, we here like the local street, we here like in the house, in the family, and then we don't have like the resources. And like I'm gonna share like in the screen. I'm sorry, give me a second. I'm gonna share my screen because I really want to talk about like basically like what we have been doing. But again, I really want to go to my screen to share you some of the work Life of Hope itself has been doing. Can anybody see my screen, the first page? Okay. Everybody see the first page?
Yes.
All right. So again, I thank again Amy again for the opportunities, and then we're located like in 1777 Booking Avenue. This is where we are, and then not too far, like 2 minutes or 5 minutes from Downstate, which was one of our partners, who's been helping us like for the last 2 years through the COVID, especially to expand our building capacity. And Life of Hope, again, community, multifaceted organizations will make impact to cultural empowerment. And one something we have to share about it. Sometimes we talk about like cultural empowerment, but there's the cultural indifferences as well we need to end. And then we are aware of it. But again, we need to have an infrastructure as well to create a sustainability to end the cultural indifferences in our community. We in Central Booking, as you said, like we're talking about community engagement of Central Booking. We are the largest after Florida, Caribbean born Black immigrants people in the United States. So if you're talking about in terms of doctors or like nurses, all these people in our fields, and again, you cannot just talking about institutions not having like people in the front people who look like the people in the community they represent, who look like people they want to serve. So all those things are very important when you talk about community engagement. And then I was talking about like the project introductions and then project like the project primary goals of like COVID or what we want to do. What we are today is that one thing I learned myself and then to Life of Hope and to the COVID here in Central Booking. Community engagement for us, it has to be beyond academic, because Central Booking or Brooklyn, we have constantly people coming, and this is what everything's began from them. They come from the Caribbean or they come other part of the world. They're here for 2 years, 4 years, 5 years, 6 years, and they establish themselves. They become better, and they pass the apartment, they pass like the womb, they leave to the next generation. So to the next one just arrive overnight or during the morning. So the way we have to tackle, or the way, because it's ongoing on renewal issues, it's not something you can say like, okay, I give like a grant for 5 years, and then what's the result? because our community is constantly renewal itself, and therefore the issue is constantly renewal itself. So we cannot just say like, we give Ngozi, I'm sorry to say Ngozi, I give an example, like, a partnership Ngozi for one grant or for XY and the money, and then we don't meet like the expectation. It's not because ourselves, like myself, like, we're not doing the work, we're not doing like, community engagement. It's because of the people coming in our community overnight and daily, did not hear permanently. And then what we have to do is to make sure we create a system, not just review things, but a system where to address those winning issues been existed for so long and so long. And that's what the new center we having, the new building we having, we're doing the acquisitions with the support of the elected official, like, from Bowall, from Badlander, from like, city, the mayor office, from the state. We've been having a lot of support, some fundings coming out as well to establish this, the center, this hub where this family, because we have to see the community as a family. I know, and we're talking about like, okay, healthcare, like, is like, healthcare and stuff, like, as one entity. But again, in our community, the importance of those CBUs, this community, when people come into us, they don't tell you the issues when you go to the hospital. But when they come to us, we have the time not only to understand the culture and differences and to understand, like, the issues, but we take the time because we have expertise too. And usually people feel like, same thing we're talking about, like, in parentheses, that people talk like, you have to have more police, but policing to who? Or policing to people in our community. The police cannot solve all the issues of our community, and we're aware of that. And then we see what happened last summer with flood, all the same. The same thing, we cannot leave everything to the hospital to solve all the issues in our community. And then the importance of the community engagement from the hospital part, from the research part, from the academic part is important. But again, the CBOs play a very important spiritual, same thing like, the faith-based organizations we have in our community, which is a lot of them. So we over the years, that's what, like, our success become, is we understand that we have to work with the churches, we have to come with the houses, we have to come like in other non-denominations, if that we, whatever what they believe, because they also plays a very important roles in our community. And that's what we've been established over the years. And that's what we intend to do. And then I have to thank, again, Downstate for the partnership, for the community engagement. We believe it's something like, we need to explain with the other hospital in our community to do the same things. And I would like to say again, thank you for the time, and thank you for all you do. And then I believe, like, there's hope. And if we not see ourselves as like, one entity, but if we see ourselves as a community entity.
Thank you, Mr. Luxama. And then I will move on. We will move on to Dr. Pardo, who is, I believe, one of your close academic clinical partners. So I'm sure she will talk from her perspective on the partnerships that you have, about the partnerships that you have.
Hi, good morning, everybody. Again, thank you to the organizers of this event. I feel like there's, after those presentations, not much for me to say, but I really wanted to be able to just share kind of the experiences working. I have two of the partners that I work with here on this panel, experiences, challenges, and hopefully best practices moving forward. I'm in the Department of Obstetrics and Gynecology, but really I am first a practitioner, community physician before everything else. Everything comes after that to me, the for better or for worse, the research and everything following. And I started actually my career in global health because I'm very happy to hear all of the conversations and best practices related to community engaged research. But I started actually in global health because there was a time where that wasn't really a central focus of our work within academic medicine or in general, the way that we're doing it now, the focus on social determinants of health. So I really learned, how to navigate communities and integrate social determinants of health at the global level, which has always been in the forefront, and really fortunate that we are moving more and more for that to be a focal point for our communities here, because the same disparities we see on the global level are the same disparities that we're seeing here. So when I, returned to Downstate and, our, obviously, the focus prior to COVID, and which is still there, the disparities in maternal health outcomes, for us, for the department, the first step was to go to the community. So we're fortunate to have the partnership of Arthur Ashe Institute of Urban Health that can really help us to convene and first listen and learn from the community and build relationships from there. Understand what the community is seeing, what the community has to say about us, what we are doing at our institution, and how we can best address their needs and take better care of women. And everything really then developed from there. Programmatic aspects of our work within the department and within the community developed from there. Research, now when we get to inquiry, both inquiry within our health systems and inquiry from the communities developed from there because of the relationships that were established based on wanting to hear from the community. So that is where our work really started, not particularly with a scientific focus or research question, but wanting to build relationship that can develop many things: community outreach, policies, programmatic, and research. And so that leads us to when it came to the COVID time period and how we can also understand what our community needs, but also how do we have meaningful interventions within our hospital and within the community. And we're fortunate to have those relationships. So one of the things, again, while I'm thinking, about what I'm processing of all the things that I'm listening, as and I'm somebody who likes to go into the community. So I spend a lot of time outside of the hospital doors, participating in programs, volunteering, just getting to know the community and the organizations. And you learn so much about community organizations and really the challenges. So I think, like, for instance, when Ngozi was mentioning how many requests community organizations have coming in, how many panels there are. So if we think about even all the different research projects, how do we, move together in a way where we're not adding a lot of burden on the community while we're moving forward, while we are making sure to maintain the principles of community engaged research, finding also the right time for initiatives. At times, there are times we're going to be where, we want to do something, and then we realize it's not the right time, whether for us, the organization, or for the community organization. Perhaps there should be a phased approach where the organization takes on the bulk at one point and it transitions to while you're building the capacity. So figuring out innovative models to really do what we're trying to do, both in, I'm a practitioner, so both in practitioner and in research in that we're trying to do. And I know, my time is short. One of the last things that, I'd like to say is that as we are, again, the inquiry and the findings in the research are essential. That is what moves us forward. That is what enables us to develop innovative programming and interventions for the community. But, always finding ways of how we can build the capacity of the community while we're doing research. So, for example, not solely, and I don't mean capacity just in research capacity, but the actual organizational capacity. So when our 1 year or 2 year runs out, how can we make the organization stronger following that tenure? Because there'll be more research projects and another program that we want to re-engage for. We have to make sure that the community is able to continue and grow. One of the things I've learned is oftentimes when we come in and we infuse funding, it increases capability and also expectations of the community for that organization. And then when that time ends, that expectation is still there. And how can we make sure that the organizations are able to continue their work and then are still able to be strong partners for us moving forward. If you haven't heard of the term accomplice, so again, that's kind of going to that. How can sometimes it means, I think somebody mentioned this, a grant proposal may be more appropriate to be submitted by the community organization in which you assist. At times it's more appropriate for you, the institution, with the community organization as a subcontractor. So again, I'm seeing how we are enabling the community while we are continuing with our programs. And the last thing, I want to acknowledge something that our keynote stated earlier, Dr. Perez-Stable, which I thought was really important. And again, that goes to the individual determinants that you mentioned, that, we communities are not monolithic. So, and the community here in Central Brooklyn is different from the community in North Brooklyn, is different from the community in Harlem and the Bronx. And so making sure that we are finding ways to integrate the intersectionality, the cultural, the religious aspects of communities into our work. So for me, when I'm working with different communities, I look at which organization I think will be the best partner. Here in Brooklyn, we have a large immigrant community from the Caribbean, and Life of Hope was a natural partner for that. Although they were not doing as much within health, they were focused on largely on immigrant families. We wanted to work on doula work and perinatal. Groups like Brooklyn Perinatal Network and Caribbean Women's Health Association were natural partners for that, because they have a long history of doing that type of work. So recognizing, it's not a one size shop for all that we are doing, and seeing the best way we can integrate the intersectionality and all the determinants of what we do. So I will pause there and thank you again, for the opportunity, and thank you for everybody and all the panels for the work that you're doing.
Thank you, Dr. Pardo. And I think the panel really brought to light, what the communities are doing, and, rethinking, the need for rethinking of how we can share the work and what we do in public health and addressing health disparities. I'm going to have Dr. Banu have an opportunity to summarize, and then maybe we can take one or two questions.
Thank you, Dr. Afable. And I want to thank the organizers for the opportunity to be here. The exposure for a transport scholar like me is invaluable. And I want to say I'm incredibly humbled to be here in the presence of those who really are walking the talk every day. While I was listening to our panel speak, what I was thinking was, this is the look back, this is the introspection of the research and community-based organizations put under immense pressure because of our old paradigms no longer work in the drastically changed scenario that was the COVID-19 pandemic. Yet ironically, what everyone mentioned, that the role of community engaged research to address health inequities and clinical and social determinants of health was even more critical during this pandemic, during this context. So this was, to me, a report card of sorts to see how we did when we had to rapidly engage, like Dr. Williams mentioned, when we had to rapidly ramp up trust and relationships, because those are the first to fall by the wayside when crises happen. And how to demonstrate that we care, because without that, there is no relationship, right? As well as was mentioned by the panelists, how to close the loop and share back ideas so they can be tried out by the community and discussed and implemented if acceptable. All while our communities are sheltering in place. And they are separated from us and we are from them, and we don't have the usual give and take that we've come to rely on, which even if imperfect was all that we had. And the panelists are speaking very loud and clear that in this landscape of uncertainty, a collaboration between academia, between clinical entities, community-based organizations, faith-based leaders, becomes even more indispensable. And we heard that we have to distinguish between theory and practice, and between academia and community. And we need to stop and think. We need to gauge partner engagement, as we've been shown with tools and models. And I heard how Boris said, and in fact, every panelist mentioned how they ramped up their capacity and how they found innovative ideas. So ultimately, what came out of this in our report card was that we need to work on these issues, and we need to put the community in the middle and circle hands around it so that we decrease the fragmentation. And as Dr. Afable said, move towards a shared accountability. And what I lastly heard very loud and clear, as long as our heart is right, there is hope. Thank you.
That was an excellent summary, Dr. Bano. And then I think I see there's a question. Someone's raising their hand. Joan Tate Headlam, do you still have a question? Joan? So we can't hear her. We also had another question for Dr. Williams. Did you keep working with the community when the grant ended? Were any of the participants able to get care at NYU, which has many barriers?
I can answer the first question for sure. So we presented to the community partners whether they would like to continue meeting and that we would support them, but we didn't have the funding to offer the honorarium as we did in the first 2 years. And fortunately, we were refunded so that we could continue to provide that incentive, but we were certainly willing to do so. The question about receiving care from NYU Langone, that was not their primary system for care. They received care specifically in their communities. So we worked in Harlem, in the Lower East Side, and those were generally where they received care, but we certainly connected them to New York City Health and Hospitals Corporations.
Thank you. And any more comment? I just want to emphasize that, I think our panelists really communicated what Dr. Bano said, a call for action. And, we're not going to end with this symposium. I heard a call from everybody, particularly those entrenched in the community, Ngozi Moses, Perez Laksama, that there has to be a higher level of intervention and as a transformation and of how we approach the health of our community, from not just from a research standpoint, but from a service provision standpoint. And I know Ngozi has been an advocate for a national model, the Pathways Community Hub model, and that has inspired me as a researcher, as well as I know a lot of my downstate colleagues as well, in terms of advocating for that type of model. And so, we share. I think what is missing in a lot of the conversations this morning is that part of community engaged research is understanding the assets of the community. As a researcher, I turn to them for insight and knowledge and expertise. And so, what are they doing already to, care for the families and the communities that we're trying to care for? We have to turn to them for that insight. I thank the panelists for really enlightening the audience on their experiences. Any other questions?
So Dr. Afable, we're going to move to the next panel because I do want your panel to have the benefit of hearing about future discussions, the discussion of what we do for the future. So Lakia,
yes,
pick it up.
Yes, so we are transitioning into panel 3, Future Directions and Capacity Building. Our moderator is Dr. Carla Booten-Forster. She is the Associate Dean for Diversity Education and Research. She is also a professor of clinical medicine in the Department of Medicine at Downstate Health Sciences University. Our discussion for this panel will be Dr. Marlene Camacho Rivera. She's a transport scholar and a postdoctoral fellow program graduate from the transport program. Thank you.
Hi, good morning, everyone. It is still morning. And this has really been a lively discussion. So I have the honor of moderating a session with some esteemed panelists to really discuss the next steps, right? Advancing the needle on community engaged research in theory and in practice as well. So what I'm going to do is I will call the names of our panelists, and if you can just give us a brief description on your work and how your work addresses community engaged research, health equity and health disparities, and some of the work that you're doing. And after that, if there is time, we will go on to some other moderated questions. So I'd like to start with Dr. Susan Bean, who's the Executive Medical Director of Health First Clinical Partnerships. We will hear from Mr. Gabe Rodriguez, Executive Director of Development for Research at State Health Sciences University.
Hello, everybody. I'm so glad to be here. I have been at Downstate for 3 months. I came from Mount Sinai Health System in New York City, and I've been in healthcare philanthropy for over 20 years. Prior to joining Downstate, I was in charge of all private fundraising at Mount Sinai's Department of Medicine, spanning 8 hospitals throughout the city. And I was also the lead fundraiser for the health system's Center for Post-COVID Care, what we claim is the first one established in the nation. I don't know if that's been verified, but it was absolutely one of the first in the country to realize that there were people who had effects from COVID after they had recovered. So I was part of getting that off the ground. I also did fundraising for the Division of Infectious Diseases, which shifted solely to COVID research at the onset of the pandemic. And I was also the lead fundraiser for Mount Sinai's Center for Transgender Medicine and Surgery, the first center of its kind in the country. One of my biggest roles during the pandemic was serving on the leadership team that established Mount Sinai's Institute for Health Equity Research, which gave me a lot of insight into the challenges that you all face in trying to find additional funding, not the least of which was convincing donors who really want to see an impact right away that research is something to invest in, especially community research. They want to see results. They want to know how you're impacting the community. And sometimes those things can seem a little esoteric and maybe not doable. And so significant funding for those kinds of things was a challenge, but we did get it off the ground. And I can talk a little more about that. But my experiences with each of these important parts of the health system, including the Icahn School of Medicine, allowed me to use my expertise in a variety of capacities, including raising private funding for numerous research initiatives. And at the same time, the onset of the pandemic brought some expertise of mine from a previous position at the International Rescue Committee into a new light for me. I never thought that my humanitarian fundraising experience for crises would actually impact my work in the United States. But here I was at an academic medical research center, and having done that most of my career, suddenly having to transition our team to an emergency crisis fundraising effort. And that was a laborious process, partially because I don't think people really wanted to accept the fact that we were heading into a crisis at the beginning. It was hard to get a team of 100 to really move in that direction, to all focus on one thing. But I had that experience before, and we finally got there, and we raised $70 million in about 6 months. But that experience at Mount Sinai also, as some of my colleagues at Downstate have heard, gave me a little bit of a crisis, a little moral crisis, because down this, not too far away from me is one of the public hospitals here in New York City, Elmhurst Hospital, which was on the news because of the dire situation they were in. And here I was at a private hospital in New York City with, at that point, gobs of money rolling in. It was, for me professionally, it felt great to be able to bring that kind of money in for our research. That was really important for our, the 10 hospital that was going up in Central Park, those kinds of things. At the same time, I was wondering where is that money going to the communities that need it? And so it was at that time I started to think maybe I need to be putting my skills somewhere else where I can actually have an impact on the community I care about, because there was a certain point where, even though I was doing some really good work, I thought, there are other people out there that need my help. So here I am at Downstate, and I'm very excited to be here. So I hope with some of these questions that we have for the panel, I'll be able to talk a little bit about some of the barriers that I've seen in funding for research in general, but also for community-based research, and some opportunities as well. And I will hand it back to Dr. Buchan Foster.
Well, we're glad you decided to come to thank you. Okay, so Dr. Bean, yes.
Absolutely. As all of my fellow panelists and the various presenters have said, it's an honor to be with you today. And especially for me, as I represent a member of the managed care or industry. Health First is a health plan that's not for profit, formed by the majority of voluntary hospitals in our region. And our mission is really aligned with promoting equity and the best possible health outcomes, along with our sponsors and our providers in our network. My team is called Partnerships for Medical Outcomes. We were actually created as a recommendation of members of the board 12, almost 13 years ago, feeling that healthcare should be more than a business model, but if we're going to really impact outcomes, especially quality outcomes and performance, that providers need to have a say as stakeholders at the table in how they are using evidence-based medicine to change outcomes. So that's the heart of what my team does. We actually have 3 pillars. One is called clinical transformation, where we share data with our PCP and other practices so that they can do their own performance improvement. We have an optimization group that actually can give technical assistance across a practice around practice processes. I think what's very interesting for all of you today is our research and policy team. And that's a team that has worked with some of you who are here today, as I have, around the challenge of access and equity, around the challenge of finding not only evidence-based models of care, but evidence-based models of care that can actually impact the kinds of populations that we serve. We, together with our provider partners, serve about 1.7 million members in the New York City region. And you can, if you were to think that we're probably serving many of the communities that were adversely impacted by COVID, you would be correct. But they were already, as you know, having impacts before that. So I've learned so much today in terms of how we think about our communities. And I really appreciate all of the presenters. But I think that what I'd like to contribute to this panel is in the thought about the importance of sustainability and how we move, as I think it was a while ago. I think our colleagues, Barb and Angie, said that the community is not that interested in research, but they're interested about informing action. And I think that is where Health First is attempting to be an important and meaningful collaborator. Thank you.
Thank you. Thank you. So our next panelist is Dr. Zahira McNutt, an Assistant Commissioner of Bureau of Public Neighborhood Health and Department of Health and Mental Hygiene. Dr. McNutt.
Hi, good afternoon, everyone. It's a real pleasure and honor to be in the same space with you all and to be tackling something that I think is quite challenging, right? And often written really well on paper, but performed quite poorly in practice. And so I really appreciate this group that's bringing forward best practices and bringing forward sort of a transparent conversation around community engagement and research. As mentioned, my name is Zahira McNutt. I am new to the New York City Department of Health and Mental Hygiene as the Assistant Commissioner of the Bureau of Brooklyn Neighborhood Health. And it's been an interesting journey in relationship to focusing on public health, human rights, and humanitarian response, which is where my career has sat for the last 15 years. The vast majority of my work has been outside the US, so in other parts of the Americas, in East Africa, in the Middle East, and in South Asia. And I come to research as an implementer. And so someone who has been doing public health programming in diabetes or heart attack mortality or focused on maternal mortality, thinking about health education across a variety of disciplines. And so in wearing that hat, I love, as Dr. Bean was mentioning, I'm often coming to research because we're trying to figure out how to solve an intractable public health problem. And I think many of us, that's what brings us to that space. My own research is really focused on health systems being able to respond in crisis. So what does that look like, particularly in forced migration? So what does it look like when large groups of people cross international borders, which feels very timely to the current situations that we're seeing in the globe? And particularly thinking about how health systems and public health structures respond to those mass migrations and crises, and how we react to the long-term needs of folks who are forcibly displaced. My most recent work has been in the Kingdom of Jordan in response to Syrian migration across that border. And I highlight that just to say that that kind of work requires such a deep level of community engagement that that's probably where I got my own learning about how to do it well, how not to do it well, what it looks like when we're getting it right and what it looks like when we're getting it wrong. And so I look forward to contributing in that way in this space. And by no means, I think I'm an expert in this domain. And I think that's part of the conversation, is when we're in our ivory towers, that we're not the expert in what it means to engage community. And so I was so delighted in the last panel to be hearing from community-based organizations putting forward their expertise and pushing us and pushing the boundaries. So I look forward to today's conversation and to the opportunity for transparency and honesty around what we get right and what we don't get right, and the things that we're not getting right, why we're still doing it, and what opportunities exist for modifying, changing, transforming, dismantling to the best of our ability. And so real pleasure to be in community and connection with you this morning turned afternoon in a few minutes. Thanks so much.
Thank you. Thank you. And Dr. Sutton. So Dr. Victor Sutton is the Director of Preventive Health and Health Equity and Principal Investigator of the Community Engagement Center for the Jackson Heart Study and the COVID-19 Health Disparity State Team Lead for the Mississippi State Department of Health.
Yes, well, thank you. And thank you for the invite. It's been a great morning. Been a great morning, great conversation. Again, I'm Victor Sutton. I appreciate the invite and just some of the geographic diversity coming from Mississippi. Seeing about all my northern brothers and sisters up there and eastern brothers from the East Coast as well. So again, I'm director for the Office of Preventive Health and Health Equity, and I run programs in chronic disease, injury and violence, and school and community health programs across the state. Whether that's diabetes, heart disease, and stroke. We have a number of public health programs. I don't consider myself a researcher, although I am leading some research efforts. As I am PI for the SEAL project, and was mentioned earlier with Jackson Heart Study, which is the single largest study on African Americans in the country. It's been around for about 20 years, and I direct what we call the Community Engagement Center for the Jackson Heart Study. So I'm excited to do that. But more specifically with this work is that I led COVID response efforts around health equity for the state. And if you're familiar with Mississippi in any kind of way, you know that we're on the worst first list. If there's a list to be bad at it, Mississippi is usually at that top of that list, or saying thank God for Alabama. But not when it came to COVID. We're one of the leaders in COVID response for equity and equity response in that population. We have higher than the national average for first, second, and booster doses in African Americans and our Latinx, Latino population. And of course, we do have the numbers as with our small Asian communities with over 80% compliance in those areas. So a lot of our work evolves around policy systems and environmental change, what we call PSE, as well as working with our partners. Our work is engaging the community by informing, consulting, and involving. We all know that there's a lot of problems in the community, but that's where the answers are. Oftentimes, where I sit in government, we have a lot of folks that knows that have the answers without consulting the community. And I have a lot of things I hope that we get a chance to kind of talk and to kind of share some of my experience through this COVID effort, and just the enormous amount of resources and enormous amount of work, that the work wouldn't have been accomplished without properly engaging the community, asking the right questions and getting them involved. So again, I want to just again say thank you for allowing me to be here, and I turn it over to, back over to Dr. Carl.
Thank you. Good to see you. Welcome to Brooklyn. Welcome to Brooklyn.
That's right. Brooktown.
So the next panelist is Ms. Avital Havusha, who is the Vice President for Programs at the New York State Health Foundation.
Great, thanks so much. I'm going to share my screen. I just have a few brief slides. Let's see. Hopefully everyone can see that. Great. So I'm Avital Havusha. I'm the Vice President for Programs at the New York State Health Foundation. I'll be brief. I just want to share a bit about how our work kind of fits into this space, and I'm just feel so honored to be on the panel and at the presentation with all of you. Some of you I know have been our partners and grantees for many years. So I'm hoping I can lift up some of the work that you've all been doing. I come to the philanthropy space from many years in more community-based programming. And so I really try every day to bring some of those lessons learned to the work. So want to share some of those today. So in terms of the foundation, we're a private foundation. We focus on 4 priority areas really broadly to improve the health of all New Yorkers. But I just want to land today a bit on the work that we've been doing where kind of centers on the work we've been discussing today about bringing consumers, patients, and community engagement to the center. So our consumer empowerment priority area is how we call it. We could talk a little bit about the word consumer, but really thinking in 2 strategy areas for this work. One, really trying to ensure greater transparency in terms of data. We have a lot of work to do. I think we've talked about that today in terms of making data actionable for patients, families, community members. But there's been some, I think, achievements on the policy space there. And then what I want to talk about just briefly today is our second strategy that we've kind of discussed in the context of patients as partners, both in the clinical delivery setting. So in those partnerships between family members, providers, staff, and also family members and community members in the healthcare policymaking space. So really that patients should be at the center of those conversations, have a voice in terms of the policymaking sphere, and really be, their needs and preferences should be met in all of those spaces. So that's been kind of our guiding principle and North Star in our work. And we've really been most recently thinking about how we can use that space as a vehicle for improving equity, for advancing equity, for reducing disparities. We're lucky enough to be working right now actually on a project with SUNY and with the Arthur Ashe Institute on this idea of, for example, integrating a racial equity lens into the patient experience process. So really lifting up community voices to create an equity index to measure health equity, both at the health system level and at the community level. So that's one example of some of the work we've been doing in this space. And I won't go into a lot of detail on some of these select other program areas, but happy to talk more about them. I'm really kind of running the gamut from things around making sure that telehealth is really sparking and improving equity as opposed to exacerbating health disparities, especially in this moment of proliferation around telehealth. And also thinking about things like open and shared visit notes that are now required of health systems and how we can both make sure patients have access to those for decision making, but also make sure that bias and other inequities aren't being exacerbated by those notes themselves. And so really from a comprehensive approach, thinking about how racial equity can be the lens for some of these patient engagement initiatives from our funding perspective, and also when we're informing larger scale best practices and systems change. And then I think I just wanted to raise up some lessons learned that we've heard. They really mirror a lot of what all the panelists today have spoken about. So I'll just speak really briefly. But really one of the things that we've often heard from our partners and grantees is this idea of addressing kind of these practical barriers to do this work. Everything like for one example, one of the things I've talked about a lot recently with partners is even the IRB process, which of course is critical for protecting patients and community members. But also, there is sometimes a disconnect around how do we really do this co-design work meaningfully in the context of some of those research protocols. And so I think those are some of the things we can work on together. Similarly, where are patients and consumers coming for their input. Are we meeting them in their communities? What times of day are we meeting with community members and patients? And then secondly, this idea of inviting storytelling. This has come up a lot as a theme too throughout the day this morning. This idea that we oftentimes are asking patients to tell their stories, and those might be stories of challenges and things that didn't quite go right. But what we've seen from our partners is also this idea of, as Amy said, about assets and creative solutions that patients and community members might have a story to tell, but a challenge. But what's come of that is often a really creative solution into the design of a new potential way of doing things. And how do we create infrastructure to get those stories and solutions back into the health systems and the policymaking sphere? And then, using a trauma-informed approach, as we've talked a lot about today, obviously, COVID exacerbated a lot of long-standing trauma, whether in terms of racism and other issues. And what we've heard from partners a lot today as well is that when we're talking and asking community members and patients to bring their stories to the table, we need to be cognizant of how to do that in a trauma-informed way and bring resources to bear to help community members and patients manage some of that trauma, mental health issues as they're participating in our programs. And then last but not least, which is again a theme of the morning, is really this idea of long-term commitment, sustainability. This work takes time. As a foundation, I would say we of course really need to recognize that there's not overnight outcomes necessarily. There's a lot of work to do to build culture change and these long-standing trusted partnerships. So we'll end on that and turn it back over.
Thank you so much. And thank you so much for your support on some of the work that we're doing here at SUNY. And last but not least is Dr. Marilyn Frazier, who is Chief Executive Officer of the Arthur Ashe Institute for Urban Health. She's a research associate professor in urban health research. She's an associate professor in the Department of Medicine and the School of Public Health at Downstate Health Sciences University. Dr. Frazier.
Thank you, Dr. Carla Buden-Foster, and it's just a pleasure being here and just being a part of the panel. Just to tell you a little bit about the work of the Arthur Ashe Institute. The Institute was founded going on 30 years now by Arthur Ashe, and when he founded the Institute, there were 4 tenets or 4 pillars, and those things are still important today. And it's amazing, in 30 years, these things are still relevant as well. One of which is community-based research and community outreach, and going out into communities in which we live and making sure that people are aware of health, and that we are teaching folks to do preventive medicine and preventive health care, and also ensuring that people are linked to services. And one of the things when Arthur Ashe founded the Institute in terms of community outreach, he wanted us to be cognizant of the health of the communities where people live, but also for the communities from which people came. So whether people were from different countries or different states, that we were cognizant of the healthcare systems there too, because he understood that those impact our health. And so that's one of the things that we do. And we do that by going out into barbershops and salons and training barbers and stylists so that they can talk to their customers about health. And then conducting community-based research to see whether those stylists and barbers delivered messages impact the health behaviors of their clients. And as a part of that work, we want to make sure that we are linking people to services, and we partner with community-based organizations to do so. A second core piece of our work has been increasing people of color in the health professions. And we do that through our Health Science Academy program, which is a pipeline program for students that are interested in the health professions, because we know that when we look at the health professions, we know that it's not diverse and it doesn't reflect the people that we serve. So making sure that that happens, we have a Health Science Academy pipeline program that starts from middle school and goes through high school. And we hope that we can sustain that over a period of time and increase diversity in the health professions. A third piece of the work has been partnerships, and we could not do this work without partnering with community-based organizations. We serve as a lead organization of the Communities Together for Health Equity, which is a community consortium that's made up of about 75 community-based organizations across New York City. And we work closely with those organizations to address social determinants of health, things that were really highlighted, which we knew that they were there before COVID, but they were more highlighted as a result of COVID. And finally, the fourth piece of our work has been policy and making sure that that policy is informed, and that can be informed through research, through community-based research. And we know that if we do not change policies, then the work that we do is in vain, because we do really need to dismantle systems and break down structures that produce and replicate those health inequities that we see. So I look forward to speaking more about the work of the Institute and also some of the work that all of our community-based organizations or faculty or medical care organizations are doing. So I turn it back to you, Dr. Buden-Foster.
Thank you. So Dr. Stricker, we have time for a few questions. I don't see any questions, but I can start. Okay, so thank you. So what I really enjoyed about this conference and gathering so far is that we're having real talk about racism. And we often hear about the COVID-19 as a pandemic, but as we know, in communities of color, it was more than a pandemic. And social scientists have used the term syndemics to describe, really, you have the COVID virus, you have underlying health conditions, but it's clustered. It's clustered in communities of color. And then there's this underlying pervasive, longstanding history of not what we call disparities of social determinants, but racism. And this conference has really allowed us to elevate conversations about this wicked problem of racism. So how do we leverage the resources and the assets and the knowledge of our community in a process known as community engaged research to address not disparities and inequities, but systemic racism, really, which is the fundamental driver. So let's move upstream. We're not going to talk nice anymore. Real talk.
I would like to comment and go see more.
I knew it.
And I want to get very real here, not esoteric or theoretical. Right here in New York City, we have a large organizations that control the influence and the resources, the contracts of community-based organizations, and whose boards are run and have no reflection of the distribution of the organizations that they're even working with. And are at the table representing when the money's coming, those very organizations that they claim to be partnering with, which really it's delivering contracts for services, but not really engaging. And all of the talk we've had so far with COVID and inclusion and a lot of webinars, there seems to be no movement, no accountability of these large organizations to try to shift what's happening in the male white boards. Do not think ability to make that happen. And a lot of the racism that happens, it happens at the top of people who don't even know they're racist, or they think they're not racist because they use the nice words, the phrases, the cliches, and the tokens, the things of token. I have sat on too many conversations. I've been engaged in too many workshops that talk about what needs to be done. And in my earlier comment, I talked about theory versus practice. Now, right now, as a lot of money is coming into our city for COVID, and everybody is on the bandwagon of equity and inequity, let's just see how things change and how that money gets distributed. How do the community organizations on the ground in the trenches, where are they represented? Who is speaking for them? And I think when we talk about racism and equity, we have to talk about influence and power. If we're not changing that equation, we're just talking.
No, thank you. Thank you very much, Ms. Moses, for sharing that. It is true that we do have to look at power and privilege, right? Influence and power. Other members?
I'd like to add that post George Floyd and post inequities seen through COVID how many corporations did you see come out with, press releases and statements about all the money they're putting toward equity and health and anti-racism? Every major company put something out there that they supported the protests, that they are committing philanthropic funds for our communities. And where did that money go? The Washington Post did an incredible analysis in the fall showing where that money went, and it didn't really go to many places that are doing the work and that are actually on the ground creating change. And that is very disappointing, to say the least. And part of the thing that one of the things I want to do in my role at Downstate is make those companies pay up, because they've made all these promises. They got a lot of great PR for how socially committed they are and how anti-racist they are and how much they support communities, and where they're actually putting that money isn't where it needs to be. So that's another, talking about, as Marcus says to everyone here, it was performative. And it's, I was infuriated when I read that article about where this money was actually going. So I think for all of us here, regardless of the size of your organization, you need to go to those companies, especially if they're in your backyard. Do you have an Amazon warehouse that depends on healthy workers? Do you have a Coca-Cola bottling plant? These companies care about their bottom line first and foremost, and they want a lot of great PR from their grants that they make. So you can work with them and say, okay, great, give us this $500,000 and we can do all the pretty things you want to share with your customers, but help us ensure that the workers that are going to your plant are taken care of. And that's just keep that in mind as a source of funding for your research as you work in your communities.
Dr. Collum, I feel an obligation to be brief because we have such a dynamic panel. And so I want to just be real quick. And from my perspective, I think Ms. Mosel raises a great point. We all during the day, we talked about power sharing and what have you. And I think not being a researcher and being on the outskirts, when I see partners, I see if there's $1 to be shared, I see 95 cents going to the university and 5 cents, if 5 cents going to the community. But in the larger scope of COVID, I say leadership matters. And I do say a lot of it's structural. We had conversations with our health officer and with our Black caucus and other things, and to ensure that these millions and millions and millions of dollars is being spent around COVID landed in some Black and brown organizations and Black and brown pockets. And that's really has to be really deliberate. We talk about even communications. And I know that there was some documentation nationwide about how many of those dollars went to minority advertising firms and minority creative type groups, and it had to be delivered. I can't say the work that we've done. Had it not been for my boss, who's the state health officer, allowing me to go off script and use the emergency declaration, I wouldn't have been able to work with Black firms because of folks who have the contract with our agency are all my majority serving organizations. And so it has to be very deliberate, and you have to get to the right person to get some of these things done. And just real briefly, I would say that I know that we've heard a lot from this group about power sharing and sharing resources, but I think we need to look at the funders and then where it has to be in that application to ensure that other folks and other communities are getting a piece of the pie.
Excellent point. Thank you. Thank you. So that actually feeds right into the next topic, which is that much of the resources have come from large funding, either PCORI or NIH or large state agencies like New York State Health Foundation. But how do we, what are the steps that we need to do to reallocate, not to reallocate, but to really flip the script? So for instance, an RFA that comes out, academic institutions just jump on it. And then we find community partners, let's be honest. But an RFA that came out that went to community-based organizations and said, that's the lead. And then the academic institutions would be the subs. So that's, I think that's out the box thinking. So what's your perspective on that? And it answers the question that you're talking about, Dr. Sutton, and also Ms. Moses, reallocation of power and who really handles the money when it comes.
So this is Susan. So I would like to comment on this, and I have to comment after my mentor, Ms. Moses, has already commented anyway. So, but you know, I do think that on the healthcare delivery side of things, and if we include managed care organizations in that mix, then that's where the structural racism is. And that's where people experience it. So I do think that there are many evidence-based practices that are known to improve long life with quality for all populations. In addition, there's been some amazing research, some of you have done, around specific populations that we're serving. And Health First has been, very lucky to work with you with, how we can impact our members. And I'm very lucky. I want to echo what Mr. Sutton said. I'm very lucky to be with Health First in a value-based model where our sponsors, our providers, our partners are always looking for ways to flip the script, if you will, so that value flows everywhere. And from the equity point of view, I work with our doctors and others to make sure that patients, members, clients get some of that equity and that value as well. I think the challenge of the future is going from grants. I don't mind whoever funds it. Thank you very much, funders, to implementation, to in a way that's not research, where we can go from what we know about how populations can be. Is anybody going to argue with me when controlling blood pressure will change the trajectory of people of color's lives? Period. I mean, that's not even, no one's going to argue with me. But I think our next work is for organizations like mine to make commitments to make that sustainable, right? And to do all of the things in the community that give power to our members. Part of that is allowing them to work with community-based organizations. My challenge to all of us is, whoever is a fiduciary or whoever can impact the fiduciary or whoever just has a loud voice, let's implement evidence-based practices, whether they're social service practices or economic benefit practices, or certainly evidence-based medicine. We have to implement. And I think that, I was really, Zahira, your work always fascinates me because things happen to people in disasters. None of this is a mystery. This has been proven all over the world. Yet pandemic happens and we're like, what should we do? So my plea is for us to take away from all of this important work that's done today is to really be advocates for the structural institutions that are our healthcare delivery system to implement evidence-based practices demanded. And then the power shifts back to our community.
Thank you.
Thank you for my rant. There.
No. Thank you. Thank you. This is all important discussions that we're having. So I see Dr. McNatt, Ms. Habusha, Dr. Fraser, and Ms. Moses, and just in the order that I see.
Great, thank you so much for this line of questioning and commentary. And in total agreement, Dr. Bean, around the fact that there's so much knowledge we already have. And I think there's something to be said around, and I have sat in government, in academia, in nonprofit, there's something to be said about research being very much about career progression, research being very much around bringing money into institutions that already have large amounts of funds. And so if we have to sort of confess our position and our guilt in the structure, right? So I feel like we're often trying to point out what's going on around us that isn't fair and isn't just and isn't righteous. But oftentimes these conversations give us a moment to sort of turn inward and be able to lay bare where we've gotten things wrong. And so in these questions that Dr. Bean is mentioning around things we already know, can we just do them and fund that being done? Part of the reason that doesn't happen, right, is because we want to write and we want to publish and we want to put work out. And so we're asking the same question 12 different ways over the last 20 years to get the same answer. So I think we have to figure out like what's the culture of our own institutions and how do we not allow that to be the way forward. But then in response to your question around how we change power dynamics, I mean, I think I love the conversation around money, and I would love to talk about two different aspects of that. So some of the most, I won't say radical, but some of the most interesting donors are investing in relationship building. Sorry for all the background noise, but some of the donors that are doing the best work in this space are investing in relationship building. They're not saying, give me a research question, give me a project. They're saying, oh, you academic institution and government body and community-based organization want to work together. Here's money just to build that relationship. So it's authentic, so it's rich, so it's long-term before you even come up with an idea. And so I think there's something about money for building partnerships that are real and that are strong and that are long-lasting and that are mutually beneficial. But then the other piece of money I'm hearing folks talk about, which is why should government bodies and university partners get all of the funds, that 95% to 5%? Why aren't we just giving money to community organizations and to community bodies to lead research and to be the leader and for us to learn how to follow? And I think in every ivory tower I've ever sat in, we struggle with followership because we think that the brilliance is inside the four walls of our institutions. And yet when it comes to public health practice and implementation, it's not in here. Right? If we confess, like that brilliance is not in here. And so I would love to say that part of what we need to do moving forward is literally moving the money from the hands of one group of people to another group of people, and then investing in the relationship building. And I think if that happens, then the power has to shift because the power follows the money. I'd love to, continue the conversation in many other directions, but I'll pause there because I'd love to hear from other colleagues on the panel.
Zahira, I have to tell you that you'll be glad to know that in speaking with individual donors, and they are the ones who really can write the big check that you need. Foundations and corporations have their resources, but it's really an individual philanthropist who can make the difference for all of us. The first thing they ask is, who are your community partners? We're at Mount Sinai talking to them. They can write a 7-figure check right there. And if you don't have that authenticity of the work on the ground, a lot of them don't. They're skeptical, and they should be. And so, even though it was tough for me on the end of the person asking, it's a great question. It's like, who are you actually working with? So they know and they want to know. And so there is a way to flip that script, flip the dynamic, and bring your community partners to the table. And I love the idea of making one of them the primary, and making Mount Sinai or Downstate the secondary. It could go a long way for you.
Thank you. Ms. Halusha?
Thanks so much. So I know we only have a few minutes, so I'll be brief, but I would first acknowledging, I think, even that the New York State Health Foundation, we of course have work to do in this space as well, but just wanted to highlight, I think some of the places where to a lot of your points, some of the places where we've been most successful have been when we funded those more advocacy level initiatives where it's community partners being brought together to advocate for whether it's policy or systems change, or place-based initiatives where the community partners are kind of the anchor or the kind of quarterback, so to speak, in those efforts. And I think those are the places where we've learned so much about the power of both individual community-based organizations and then their collective voice as well. In particular, I would say the program area that I described, we've really been able to use that approach, but I think there's a lot we could do to kind of spread that. We typically don't fund more kind of research in the traditional sense, so it allows us to really bring in some of those community partners to be the lead, and often there might be an academic partner in evaluative capacity of some sort. But I think for us as funders is really kind of really lifting up those lessons from especially the community partners who are working collectively and with community members. And in addition, I would just add one other point about the funding. In addition to the dollars, maybe, kind of shifting from the university setting to the community-based organization, also to the community members themselves. individuals. And I think we have a lot of work to do there too, but in some of these initiatives that I just described, we've tried our best to carve out, I wouldn't say it's necessarily sufficient, but dollars to go to patients, to consumers, to compensate them for their time, their ideas, and their expertise. And I think that's another challenge to put on the table for us.
That's a great point. I like the way you said compensating for their time and ideas and expertise and contribution, really. Dr. Fraser.
Yeah, I know that one of the things that's always frustrating is that we know the answers and we know exactly what probably needs to be done, but getting it done and implementing it, that's the big problem. And I think even when we think about giving funds to a community-based organization or developing a program, or even something as simple as the application process for NIH or so on, community-based organizations may not have the capacity to do that. So we need to even go there and switch how things are even sent out, like what's expected when you're writing an application out to someone. Everything might be researchy and research-esque in some sense, that and community-based organizations may not have the capacity to do that. So I think to be real, I know power is something that's hard to give up. And I think although we may want to do that, a lot of people do not want to relinquish power. And it really means that you have to relinquish power. And to do that, academic institutions have to do that, funding streams have to do that. And it's something that's difficult for folks to do, regardless of all the different ideas that they may have. So I think we really have to dismantle the systems, like really go and really dismantle, break down walls and dismantle systems, because we'll keep on having the same discussions and the same ideas out here. But if the systems are not dismantled and systems from the funding, the way that funding announcements come out and the way that people need to respond to those, the way that streams are in place, even when you think about promotion and people that need to advance their careers and what that means. So I think there are all those systems that need to be dismantled and people need to give up the power.
Thank you. Ms. Moses.
Because I like to be real and practical, I'm going to try an example here by just challenging ourselves on this. First, I'll make a statement. When I ask the question, who is accountable, it's really it's a rhetorical question, because we're all accountable. There is no power source that can point to someone and say, you write a big check and put it here and do that. So each of our organizations who have the influence and the power to do something need to make a commitment to do something. And then those who have that commitment to do something need to band together and start doing something. And the little somethings can add up, and then it will be, like they said, the snowflakes collecting the snowball. So asking the question, how are we going to flip the script and who's going to make the change, is really asking those of us who have the influence, the money, or who have the connections. And I want to use an example. Marcus, you are here and you are a fundraiser for our SUNY institution with all the knowledge and the capacities of how to tap private donors. SUNY is in a community that has been hard hit by the COVID, and I'm not pointing a finger at you, I'm just using an example. It's been hard hit by COVID. It has the community it surrounds has a lot of community-based organizations like Brooklyn Perinatal, Life of Hope that was on here, and some others who live from grant to grant, episodic funding, no sustainable way to keep the services except our creativity, getting from one grant to the next. And I can tell you, we use a lot of creativity to continue serving our consumers when one grant ends and you have to turn another one. What does it take for a group of folks like you who can come together and make a commitment to community-based organization in the area in which you operate to say, we are going to come up with a plan to get these donors that you know of, that you have influence with, that you can identify, to focus on a funding stream. What we need is we need a commitment to a funding stream that can sustainably fund and give community-based organization the capacity to serve, but the infrastructure in their organizations to be able to serve. You know, I can get a grant from Robert Wood Johnson or maybe Avusha on the line to do a project and hire an evaluator. I have no one inside who could relate to that evaluator. So that evaluator comes to my agency and that evaluation bears down on us with what the evaluator feels is the thing to do. So where are we? So the capacity needs to be inside the organization for the organization to reach to the other side in the academic community, and then to have equality in how we engage and the value. The government, I believe that with all the money that's flowing in here, there needs to be some pressure on the government to create a community-based capacity building sustainable fund. Because this money is going to come now that we have a good government, and when you have another bad government, you're back to where you started. So what is a sustainable way to leverage this moment, engage all these folks that are making statements that have money, but nobody is monitoring where the money go, or you can't tell, and create something? We can't do it ourselves. We are not at those tables, you know? So I'm saying that let us start somewhere, do something, start where we can, and you will be surprised to see you might have a model that others may pick up on. If it could be done in Brooklyn, New York City, maybe we can do it. And before you know it, there is, you know, there's a model of people getting together and taking that, being accountable for making sure something happens. I work in a collective process with community-based organizations. We have taken it upon ourselves to write grants when we have the money, partner with others to write grants, and bring money in, not just for ourselves, but for our partners who work together. And a lot of our partners are sustained because we do that, because by ourselves alone, we can't do anything. Yeah. So that's an idea for starting to think a very practical and doable for flipping the script, flipping the switch, flipping the money, whatever. Just let's start somewhere. Otherwise, we'll just keep talking.
I like that. That's a nice title for the paper. Like, you flip houses, let's flip the script. Dr. Rivera, thank you so much, Ms. Wilson.
Thank you. And I wanted to jump right in and talk and really just elaborate on what Ms. Moses was saying about the need to not just talk about it, to develop a plan. We have everyone here at this table to be able to develop a plan that we can begin to model, that can serve as a model and moving forward. And so I have the privilege and the challenge to be able to summarize, all of this incredible discussion, not just from this last panel, but also I think incorporate some of the earlier reflections that we've had from other panelists around sustainability. And I came and I jotted down sort of 6 key points that we could think about as a potential roadmap to begin to develop this plan together. The first is that community engaged research is not just, it's not a method. We talked about it as an approach. Many of the panelists talked about it as a way of life, extending beyond just our professional into our personal and everyday spaces. And so in order for us to think about it as an approach and as a holistic approach, to develop a holistic approach, there were some themes that came up within developing the community engaged research as a holistic approach. Being intentional and explicit in our values, being transparent, and being open with respect to communication, centering community, not just when it comes to the funding opportunities, but with respect to everything that we do. And thinking about community engaged research from a sustainability standpoint, not just about the research questions, but really thinking about investment into the infrastructure, into systems, and building relationships. How we go about building relationships and thinking about strengthening systems is first by examining our own power and privilege in upholding systems of oppression, in particular, starting with structural racism, and starting with accountability for ourselves but also the organizations that we're affiliated with, our institutions, and our funders. And recognizing that establishing values, communicating and transparency, centering community, sustainability, and interrogations of power, privilege, and centering accountability is is a continuous process. And so recognizing that we should not be so stuck in our ways, in our research priority areas, and what we do, what we think we do well, that we can't engage in self-reflection, learn from our mistakes, not reinvent the wheel, and also evolve. That was the third point. The fourth point around sustainability, we talked a bit about, and Dr. Berestable talked about pipelines. Dr. Fraser talked about pipelines and how as part of our sustainability is bringing people to the table. And so recognizing that when we're talking about people power and person power, it's not just bringing new investigators to the table, junior investigators to the table, recognizing who's not at the table and who it means to be able to be valued and worthy in being able to engage in this work. And so recognizing that we as academics, we as healthcare systems, as funders need to extend our training beyond just those with PhDs, with MDs, with bachelor's degrees, to our community partners, and then also established investigators in the field. If community engaged research is not just a method, it's an approach, it can be integrated into all areas of research. So recognizing that there is value in community engaged research approaches, not just in health equity research, in genomics research, in data science research, in all areas of research that's really going to be able to get us to address health inequities. The fifth point is that while we're interrogating our own internal processes and recognizing and developing holistic approaches to community engaged research, we can't stop at just asking questions and seeking answers. Is that community engaged research is about translating the questions, we know the answers, into action. And that action could be in the form of implementation of programs, as what Dr. McNatt said. It could be with respect to improving evidence-based clinical practice, as to what Ms. Moses said, Dr. Bean said, Dr. Pardo said in earlier panels, and also thinking about advocacy and translating evidence into policy advocacy and action. And the last thing that I just want to end on is when we're thinking about sustainability, we talked a lot about funding. And so we had, individuals who have been involved both in fundraising efforts and also from funding entities to recognize the need to shift and pivot and be creative and think outside of the NIH box in order for us to get this work done. It's great that the NIH is investing more money and resources in this area, but to think about private funding, philanthropic funding efforts, foundations, individual donors, but recognizing that the work can't end, it doesn't end when the money is gone.
Thank you so much, Maureen. And now there's so much more to say. And I think we'll have to have more gatherings of this sort. I want to thank everyone for your participation. You'll get a note from the Transport Planning Committee on that. And I'd like to bring back bring to the floor Dr. Moro Salafu, who can close us out.
Wow, this was phenomenal. I would like to say that it was short and sweet, but I can add one more word, which is effective. This has been one of the best conferences or symposia that I have, joined in the last year or so, because the format is just different. The format has encouraged a lot of, discussions and then free, interpretation of data and a lot of ideas on the table. It's just amazing to see everyone perform to their best and feeling free in doing so. As we come to the close of this 5th annual Transport Symposium, I'd like to remind you about the very essence of this symposium, which is the theme. The theme is about community engagement. So when you go home, just remember that word. How do we better engage the community to do what we are supposed to do. That is what everybody should just remember. We started by defining what it meant. We talked about the models of engagement, and we got to the last point, which is what do we do as future directions. So all these areas have been covered. I'm sure there is more to be discussed, but in the interest of time, we would probably build a lot of this stuff in the next meetings. I also believe that this format has actually encouraged a lot more discussion than just the bullet point, PowerPoint type kind of conferences. And so I'm very encouraged about this format, and hopefully the next time we're gathering again, we can expand this format into rooms and other things that would lead to additional discussions and bring forward more solutions to the community engagement process. I'd like to thank the planning committee, the PIs, Dr. Marcus Lambert, Dr. Carla Putin-Foster, and the support staff, Dr. Pamela Straker, who has been really, really incredible in organizing a lot of the BHDC activities, and Lakia Maxwell, our education director, for handling transport in a way that is so productive and has led to this conference. I'd like to thank our president, who has been an incredible supporter of transport. You heard what he said in the beginning. I'd like to thank Dr. Alicio Perez Stable, who has a vision that would change a lot of stuff, only if we could do all the stuff that he mentioned in his talk, but there is hope that we can. I'd like to thank the panelists, exceptional panelists, highly accomplished panelists. The moderators did a fantastic job. The discussants, I hope that we can actually put this into writing and come up with a document that actually summarizes this conference, and be able to share this a document that will be a roadmap for development and how we can better engage with the community. One word that caught my attention, not that everybody has spoken, I just wanted to highlight what Ms. Moses said. She said one word, but I want to expand a little bit more, which is start where you are. But Arthur Ashe had already said more things, right? Arthur Ashe had said, start where you are, use what you have, and do what you can. I think that is what we need to do. We definitely have to start where we are and then use what we have. We have the tools. Marlene said that all the people in this audience, we have the ability to create the plan, right? That is use what we have and do what we can. That is the transformation phase, right? Once we have a plan, we have to engage in the transformation phase that would allow us to see the result of what we are discussing today. And the last piece I want to talk about is the government intervention or involvement. A lot of the activities and plans that we have has to be within the context of community, academic, government partnership, right? That is the final pathway to change. That is the transformation that we're looking for. The research, the community engagement, and all that stuff have to actually lead to transformation. And that transformation is basically policy, right? And we cannot create policy that engages the entire community unless government is involved. So government means everything. That is the local government, the Brooklyn Board of President, the city government, the New York State government, the federal government. All of us are accountable again, right? So we have to make sure that we are advocates for everything that comes along the way, in any way that we can, in the smallest possible way that we can, in trying to get the agenda or move the agenda forward. So I'd like to thank all of you again. You can test the effectiveness of an audience by looking at the numbers at the beginning and also the numbers at the end. We are still 92% how we started, right? So that is a testament to the effectiveness of this conference or symposium. So I'd like to thank all of you for staying. Looking forward to seeing the draft of the plan, and also another symposium that's inviting all of you to the panels. And then we can have more discussions and expand on what we can do to make a change. So thank all of you.
One of the group, we have to thank our CME.
And the CME, yes, absolutely.
Without them,
yes,
nothing
absolutely.
could have been accomplished.
Absolutely.
So Edeline and Judith, thank you so much.
Thank you.
Thank you.
Okay, so with that, we conclude. And thank you very much again.
Bye-bye, everybody.